Good afternoon. My name is Dushyant Sahani from MGH Boston, and as a president of the society, it's my huge honor and privilege to welcome you all to our 40th annual meeting of the SCBTMR to this beautiful city of Nashville. Now, as we enjoy this great city and weather, we are also cautiously watching the destructive path Hurricane Irma is taking through Caribbean and southern Florida, and we keep them in our prayers, the people of Florida and other parts. So first I want to thank everyone who is here. I want to thank Gary and the search committee for putting together this amazing program, and this is only possible because of the expertise of faculty and their time they share with this to teach all of us. Also, I want to thank the corporate sponsors for providing a generous support and coming here to this meeting. If you have any problem regarding CME, the instructions are at the front desk. They can help you, and the deadline to claim the CME is December 8th. I hope everyone has downloaded the app Crowd Compass. Did everyone download the app? Okay, so if the app is great, you can download and you can look at the schedule. You can all the talks are there on the app, and you can also evaluate the program. Also tonight we have SCBTMR mentoring event. So it's Arti Sekar has put together a TED Talk-like event, which is from 6:30 to 7:30 on 4th floor in Bassroom. So if you are interested, kindly join. I also wanted to share with you that under leadership of our past president, Eric Paulson, we are looking at an arrangement of the society with Journal of Computed Axial Tomography, JCAT. So there will be a lot of opportunity once these arrangements are formalized for young faculty and trainees to contribute in various capacity, including serving as a reviewer. Also, society plans to start something new next year. We will have some webinars. Every quarterly, we plan to have webinars on some important hot topics. Having said that, I want to introduce Gary Gold to give an update on the program committee and this year's program. Thank you.
Thank you, Dushyant. And I'd like to thank the program committee in particular for all their hard work in putting together the program for this year's meeting, and also thank you, the members, the fellows, everyone who submitted topic ideas or potential talk ideas to the program committee. We're very fortunate to get many more suggestions and ideas for talk than we can accommodate in the program. But please keep the ideas coming. This year, in the program in particular, we wanted to focus a little bit on changes in technology and changes in healthcare. So I'll highlight a couple of sessions. Tomorrow, our keynote talk is going to be from Keith Dreyer on big data machine learning and AI in radiology, which is a very hot topic across the field. And following that, we're going to have a session on the impact of technological advances in radiology. Later in the week, we're going to have a session that's focused on things beyond the reading room, which will talk about cost and how you might structure your practice or clinical trials at your institution. We also have several exciting debates, including a very topical debate on gadolinium contrast agents that will be co-led by Scott Reeder, who was just testifying at the FDA earlier this week on the gadolinium deposition we see in some of the normal tissues after administration. So I think this is a terrific program. We have the usual mixture of great lectures highlighting cutting-edge technology in CT and MR with some of these new important topics in the field. So thank you and welcome to Nashville.
So we start the session. The topic of this session is CT technical advances, and our first speaker is Hans Christopher from Stanford University, and he will talk about advances in CT technology.
Yeah, good afternoon, everybody. It's a real pleasure for me to be here and an honor to speak right after the welcome as one of the first speakers at this symposium here. And I have the privilege to talk about advances in CT technology, although this is a very broad topic. And of course, because of this, I have to focus quite a bit. And also, we will hear about next iterative reconstruction. I thought it might be a good idea to talk about detector technology and the different application of different X-ray spectra in CT imaging. So, see how I can advance these slides here. Well, where is down here? Okay. Oh, there we go. Okay. So this is my first slide here, and I found this slide quite interesting because it shows quite nicely what happened with CT over the last decades. And as you know, CT is clinically available since more than 40 years now and started as a basic brain scanner in 1970, went up to a whole body scanner shortly after, and then became way more faster with the introduction of slip ring technology and continuous rotation. And then from then on, in the early 1990s, the first dual slice CT scanner was introduced, and introduced something that was then called the slice race, that started with a 4-slice CT scanner. Then shortly after, 16-slice CT scanners were introduced, 64-slice CT scanner, and then in the end, as you all know, we are ending up here with 320 and 256-slice CT scanners. And this diagram here puts up the question mark if this is the end of the slice war. I think you're all pretty aware of the fact that there's new technology coming up, what is photon counting CT, detector CT, and I will go into this a little bit in a minute. So, there we go. What also is in the mind of the public is that CT is associated with an increasing amount of radiation. And this diagram here puts it nicely together. The increase of the collective effective dose that happened over the decades here from 1980 to 2006 in comparison. And as you can see from the diagram here, CT contributes a major part to the overall collective dose over the years. So there's certainly some need to try to improve this, to try to reduce the amount of radiation associated by CT investigations. One of these attempts you're pretty aware of certainly is to try to use lower kV settings in order to reduce or to change the X-ray spectra in a way that it's getting closer to the K-edge of iodine, what helps to improve and to make CTA applications more efficient. And these are just some few examples here. For instance, in this publication here, and this has been worked out in numerous other publications, in this paper here, it's been described that this technique of lowering the KVP helps to reduce the radiation by a factor of 4. Here, namely from 8 millisieverts to 2 millisieverts, a CTA of the abdominal aorta can be reduced with can be done with substantially less radiation. Also, this game can be played in different directions, meaning also the amount of iodine can be reduced for patients who have, for instance, renal insufficiency. In this paper, this is nicely been shown by keeping the radiation the same but lowering the kV. The iodine concentration can be reduced, and by this, the amount of iodine the patient is being exposed to also can be reduced. Also, this can be combined, as shown in this paper here, reduced amount of iodine by the reduction of contrast concentration being used, and also this goes along with a reduction of radiation by about 20% from 5 to 4 millisieverts, for instance. Others are using this approach to improve image quality in general. Here, for instance, this is an example where the iodine concentration has increased and the kV has decreased, what both leads to an increase of image quality in general for particular applications such as here, the CTA of the brain. The most drastic reduction in radiation exposure we have seen in cardiac CT, and the reason is because it comes, or it came along with a technique that went along with a huge amount of radiation in the beginning, and that is retrospective ECG gating. So as you can see from this diagram here, we started with radiation in the range of 30 to 40 millisieverts, that with the introduction of ECG pulsing went down to about 15 millisieverts, and then on top of this applying a reduction of lower kV settings, the radiation could further be reduced to now in the range of like 5 millisieverts. This can be driven even more to an extreme by applying lower kV settings and certain other techniques. I don't want to go into deep too much, but here now this paper shows nicely there is the potential to perform a cardiac CT study with as little as 0.1 millisieverts, what puts this in the range of conventional plain films. This is quite amazing, and this is for CTA applications of the heart. So this is certainly a technique I guess very many of you are using already routinely. There's another way to improve radiation efficiency in cardiac CT that is, according at least to what I have seen in the literature, not so well known or understood. That is applying certain filters to the X-ray source. And for instance here, one of the approaches is to use tint filters, and by this to try to shift the spectrum more towards the high energenic photon X-ray photons, and by this shaping the X-ray spectrum more to a monoenergetic high energy photo spectrum. This helps in particular for non-contrast applications, high resolution images such as like this here for lung cancer screening. Applying tint filters with high kV settings help to reduce the radiation to a 10th or even a 20th of the dose that has conventionally been used for this application, namely here 0.1 or even 0.07 millisieverts, what again puts this application into the same amount of radiation as it has been used for plain film X-rays. This applies not only for lung cancer screening, but also there's a paper out since recently that this technique is also applicable for coronary calcium screening as seen here. And so again, those can be substantially reduced by applying certain filters, in this particular instance tint filters, to reduce the radiation exposure down to 0.2 millisieverts about. So why not combining then the best of two worlds that I have spoken about earlier, namely low kV settings and high kV settings with tint filtering and getting into dual energy CT. I'm pretty sure you heard a lot about this this morning. So this is the technique behind this, different approaches to achieve this dual spectral imaging CT scanning. This is either with dual X-ray tubes, rapid kV switching, or dual layer detectors. And you have also certainly seen numerous applications of this, and I think this is one of the most exciting ones here. The patient here on the right, so both patients here have CT-EPH, and the patient here on the left-hand side has huge clot formation in his main pulmonary arteries, but in addition to this, he has homogeneous perfusion of his both lungs. In contrast to the other patient here on the right-hand side that is also having the same amount of or even more clot formation in his main pulmonary arteries, but in contrast to this other patient here shown on the right, he has obviously perfusion deficits in the lung on both sides, that what renders this patient ineligible for surgery as such. So this has immediate clinical application. Also, this here is done routinely at our institution. This is dual energy imaging in patients who have renal calculi. This is a patient with a horseshoe kidney who seemed to have a stone composed of different materials. 3D rendering quite nicely shows that this patient has bone-dense calculi in his left kidney, but because the composition of the material of the double J catheter is different, it nicely turns out that there's the catheter here right next to the calculi, and this can be discriminated quite nicely in this 3D rendering. So the next consequent step then, of course, is moving on from the energy-integrated detectors to dual-source CT detectors, dual-layer CT detectors, and the next consequent step, of course, will be then the photon-counting detectors. And this is a graph showing the general principle between the difference between these two detector technologies. On the right-hand side, you're seeing the conventional energy-integrating detector. It is built up the following way, that the X-ray photon is converted by a scintillator into visible light, and the visible light is then being detected by light sensors. So there is an AD conversion in this detector that is taking place, whereas the photon counting energy resolving detector is a much more straightforward technology, because it just consists of a single semiconductor that converts the X-ray photon directly into an electric signal. This has obvious advantages, although this is very simplified here, and of course the technique behind is much more sophisticated. This is the first paper describing the comparison in patients between the energy integrating detector and the photon counting detector. Basically what this paper described is that the image quality is the same between the energy integrating detector and the photon counting detector. What is probably not so much surprising, we would have expected somewhat better image quality, but what we see and have as an advantage of this technology, there's always the ability for dual or even spectral imaging on the base of the data that has been created with a photon counting detector. There's something else going on in the field of CT, and this is the development of nanoparticle contrast agent CT. This sounds very far away, but if you look at the number of applications, they are now currently exponentially increasing in numbers, as well as the citations are. So there's something coming up that is probably not too far away from now. This is a very sophisticated technology, very deep in science. I don't want to go into this too much. I just want to show some application here. This, for instance, is an experiment where iodine and bismuth has been administered at the same time. And with this illustration, I just want to show you that these new contrast agents, if they are coming up and whenever they are coming up, they neatly and nicely integrate into the new detector technology, where nanoparticles or new contrast agents can be combined with a spectral CT, because this technology then will allow us to visualize the different contrast medias both at the same time in like kind of like this colorful animation as shown here on the right-hand side. I also would like to do in the end a small view into the future of CT technology. I borrowed this slide from one vendor, but this is basically the same for all vendors, and we just heard we will have more dedicated presentations on this later today. This is artificial intelligence. And so every vendor basically is working on this, and what the idea basically is behind artificial intelligence is to improve the workflow, make machines more intelligent in order to automate processes. Well, actually, I need to say I had no idea what artificial intelligence really is until I read this one article here in CNET. I hope the next slide is coming up. It's not coming up, unfortunately. There we go. So this was a nice article I read recently in CNET, and actually this was the application of Google's AutoDraw artificial intelligence on modern art. And so what the authors here did, they applied modern art and applied artificial intelligence over it to see what comes out. Well, for you, it's probably very obvious that this is a scribble of a dog that has been done by Picasso. Let's see what AI made out of this. Indeed, as a matter of fact, it recognized it quite well and made a nice drawing of a dog out of it. But of course, these drawings can be more challenging from artists, such as here. I think most of you would recognize a camel from this scribble here. Let's see what AI made out of this. Actually, it still needs some improvement, but we can believe, of course, that these technologies will get better with more experience and probably will then recognize the same thing as we will. But modern art is quite complicated, as CT is. And here, this is, for instance, a drawing of the birth of day by Miro. And again, the authors applied AI on top of it to see what comes out. And so this image, in some ways, at least from the colors, reminds me to what I showed you earlier with the nanoparticle spectral CT. And so here again, this is what AI made out of it. I'm just showing this to you that certainly there's developments going on in this field, but I still see also need for human intelligence to work on in these different areas in CT. Thank you very much for your kind attention.
Next talk on CT iterative reconstruction techniques, I invite Kalpana Kanal from University of Washington.
Thanks, Dushyant. Good morning, good afternoon. I'm Kalpana Kanal from University of Washington. I'm a medical physicist. So my talk, I'll try to keep it as non-physicsy as possible. And in 15 minutes, I just want to give you an overview of CT iterative reconstruction techniques. Before I start my talk, I'm curious how many people in the audience are actually using iterative reconstruction in their practice? So, okay, about maybe 40 to 50% of the people here. Thank you. I don't have any disclosures. So let's start by just asking the basic question, how does iterative reconstruction work? So you start out with a first image estimate, a volumetric image. You have some artificial raw data computed out of it, which you compare with actual measured projections. If they kind of match and you have reached your loop termination criteria, then that becomes your final image. But if not, you then use this compared data and use the corrected image, back project it, and you keep doing this comparison till you reach final criteria that you have determined for ending your iterative process. And this is what happens in the iterative reconstruction process till you get the image you want. That's why when you have advanced reconstruction techniques, depending on your manufacturer, you might be taking 28, 30, 40 minutes to get a final image. To start off, let's just discuss what are the different types of iterative reconstruction possible. One is the basic statistical iterative reconstruction, which is basically just modeling the photon counting statistics in a CT acquisition. And the other one is a model-based iterative reconstruction that goes beyond just doing photon counting statistics. It actually models the whole acquisition chain. And I'll talk about what each of the vendors are doing in a little bit. Here is table 1. If you're interested in reading a little bit more about iterative reconstruction techniques, you can look at these references. It's from Beister's paper. And these techniques have actually been around for a while. They've been used in nuclear medicine. It's just recently that we have started using them in CT. So from a geometric modeling point of view, we are all used to filtered back projection, which is the basic reconstruction method that's used in CT. And what that is, it's basically assuming a point focal spot has a single X-ray going through a patient, and then it's assuming a point pixel. With iterative reconstruction, and this image here on the right shows a model-based iterative reconstruction, you're actually modeling the focal spot area. You're looking at an area focus. You have multiple X-rays going through the volume that you're imaging in the patient, and then you're looking at various areas on the detector as well to give you a more accurate depiction of what's being imaged. And this takes time. So what are some of the various IR algorithms that are available in the United States? This table here shows you 4 of the big 4 in CT, as they call them: Siemens, GE, Philips, and Toshiba. The acronyms, if you're using iterative recon, you're probably familiar with some of them. If you're not, it explains to you what these are. And it talks about whether it's used in the image space or in the raw space. Where is this computation being done? Is it done in the image space or in the raw space? And as you can see, most of them are really actually doing it in the image space. There are a couple of them that do it in the raw space. So since I gave this talk last year, Toshiba has now come out also with the model-based iterative reconstruction called FIRST. And Philips has also come out with model-based iterative reconstruction called IMR. Another view of the same table actually shows you what year iterative reconstruction was introduced, around 9 years ago, and the different acronyms for the different manufacturers. GE has actually gone one step forward now and come up with something between statistical iterative reconstruction and model-based iterative reconstruction. And Siemens also now has model-based iterative reconstruction. So the big four now can offer you the basic iterative reconstruction techniques or more computationally heavy model-based iterative reconstruction techniques. So everyone has this available on your modern CT scanners. So now what I want to show you is just a few images so that you get a flavor, especially for the people who do not have iterative reconstruction, to see what kind of advantages there is to go to iterative reconstruction. So this is a CT pulmonary angio study. Image A is filtered back projection, which is what we are all used to. Image B, this is for GE, has the statistical iterative reconstructions, or ASIR. And C is the model-based iterative reconstruction, and their commercial name for that is VEO. And as you can see, and I don't know if you can see that clearly at the back of the room, but going from left to right, the noise reduction is pretty obvious, and you can see here the Hounsfield units are decreasing. The slight enhanced CT attenuation as seen with ASIR. And of course, when you compare VEO all the way to the filtered back projection, you can see how clean it is, as a lot of the noise is gone from this image. So there is some advantage of using these iterative reconstruction techniques. As I mentioned before, GE has come out with something in between called the ASIR-V. Since this was their first model, the ASIR of iterative recon, VEO is their model base, but this takes about 25 to 30 minutes to get an image. They have tried to come up with a compromise in between where they have taken some aspects from the statistical iterative reconstruction, like the noise, and then they've taken some from the VEO part of it, looking at the physics of the imaging chain, and then you're applying this in a more reasonable time, and they claim about 80% reduction. This shows you again how you could use ASIR-V to improve low contrast detectability, and I'll just let you look at that. ASIR 30% on the left, and using ASIR-V 30%. And I think if you look at this area, you can see a lot of improvement in the noise texture of the image. And since all of you are radiologists and I'm not going to try to point out what is more visible in terms of low contrast detectability over here in the image. For Siemens, again, this is a contrast-enhanced abdominal CT with liver mets showing at the arrowhead. You can also see a lot of beam hardening going from left to right. A is filtered back projection, and what Siemens has is sapphire. You can apply different strengths of sapphire, just like you can apply different strengths of ASIR for GE. This is for Sapphire 1, this is for C is for Sapphire 3, and D is Sapphire 5. I'm pretty sure nobody uses Sapphire 5. It looks too artificial for a lot of radiologists. They do not like that. At our institution, we use a Sapphire level of 2. Even 3, our radiologists find them to have a very artificial look. But the point I'm trying to make here is that as you increase the strength of the iterative reconstruction, you are reducing the noise going from left to right over here, as well as your beam hardening artifact is also decreasing. Siemens also has model-based iterative reconstruction called ADMIRE, and unfortunately I couldn't find any of my own images for this, but this is from the vendor's website, and it shows here the filtered back projection on the left and how ADMIRE cleans up a lot of the noise here and gives you a much better image quality in general. Toshiba also came out with first, I think it was about a year ago that they came out with their model-based iterative reconstruction, and again showing a comparison to their filtered back projection. Everyone claims, all the vendors claim, improved spatial resolution, improved lesion detectability, reduced dose. That's kind of the mantra between all the manufacturers. And Philips also has model-based iterative reconstruction. This is axial cardiac CT of the LCA. You can see some calcified plaque right here where the arrow is pointing out. With IMR, when you go to the model base, you can see the decreased image noise and maybe a little bit more defined plaque contour that you can see. Again, this image is really clean, very pretty. I think some radiologists from experience have a problem with these type of clean, artificial-looking images because they are more trained on the noise texture and on the noise characteristics of an image. So just to show you a couple of things in the literature, this shows iterative reconstruction as a function of lesion detection. This is the area under the curve for 4 of the vendors. Low dose, 10 milligray, and here's 15 milligray. And as you can see, the MBIR in GE's case is showing that the lesion detection is better than filtered back projection in ASIR, and similarly for the others as well. Now, we are doing a study right now. I unfortunately didn't have any data to share, but we are looking at doing a very comprehensive study right now, looking at GE and Siemens, because that's all we have at University of Washington. And we are doing a reader analysis. We have about 16 radiologists doing reader study. We're doing it with a phantom, but we're trying to determine diagnostic accuracy, contrast to noise ratio noise, and also radiologist fatigue, looking at iterative recon images, because there are much more, and seeing what kind of analysis and what results we get. Hopefully I can present that next year. Of course, one of the advantages of iterative recon is that because it's cleaning up the noise, you can dial down the dose on the acquisition front. And here is a list, again, for people who might be interested in looking at the dose aspect, several references who have looked at the dose aspect and how much the dose decreases if you're using iterative reconstruction. So I want to end by a few slides to have some thought about clinical implementation of IR, especially for the folks who might be thinking about implementing this on their CT scanners. So how do you go about doing this? You have to have section buy-in, have all radiologists on board. We are very fortunate at University of Washington. We have radiologists who are very dose conscious, and of course we have Dr. Schumann, who is very much into dose reduction and implementing latest technology on our scanners. So you have to have buy-in from your radiologist because, again, as you saw, the idea of showing those images to you was to see how different the images look when you're applying iterative reconstruction. And if your radiologists are not comfortable with looking at that image, looking at those images with a cleaner noise and making their diagnosis, it's kind of tough to have them read those images. Start at the vendor recommendation based on clinical application, maybe. So we started when we got our GE scanners, we started, I believe, at 30% of iterative reconstruction, and now we are up to, for our body imaging section, we are up to 70% ASIR. So you want to start with them. You have to make sure you are reducing your technique in dose to really make this more effective. And then you can fine-tune as you get feedback from your radiologists. And be prepared for resistance to new technology. It's always a process. It's a learning process. We have MBIR, but I would say and again, Dr. Schumann could answer this better than me, but I think we're using about 25 to 30% of the time we're using MBIR. Of course, we have to keep in mind it takes about 30 minutes, so you can't really use it for each patient, but you could use it for patients that are frequent flyers or pregnant patients or patients at higher risk. And it's a continuous iterative improvement process. Once you get it, you just don't leave it at your starting point. You're going to, based on experience, keep changing the amount of iterative recon you want to introduce in your reading. What are some of the advantages? I think everyone saw that it has a great advantage of reducing the image noise and artifacts, but it depends on the degree of modeling that you're using. It presents a more intuitive and natural way for image reconstruction, potential for significant patient dose reduction, as I mentioned, and using model-based IR seems to have better lesion conspicuity than filtered back projection, but then you have to worry of the computational time it takes as well. What are some of the disadvantages of using IR? Artificial appearance of image, I think this is the biggest disadvantage for people who read it. It takes a little bit time getting used to it because if you're trained on the filtered back projection and now you're seeing an image that's so clean, it's really, really difficult to adopt that. Increased computational effort that is needed. Evaluation of image noise and resolution is more complex, and that's why we are doing this really comprehensive study to try and really understand what's going on with the noise, the resolution, and lesion detection. As you get more and lower in CT, a low dose in CT, your electronic noise now takes a more important, plays a dominant role than the photon noise. And it's difficult to adopt by radiologists as noise patterns and artifacts look a little different. And then one question that I will raise, and I'm sure many people have thought about it, are we missing anything diagnostically important as we go from filtered back projection to iterative reconstruction? Here is an example from a paper that shows a hypodense seam along the stent seen just with filtered back projection. The image in the middle, which is constructed using iterative reconstruction, the hypodense seam is not visible, and using interventional angiography, that hypodense seam has been confirmed. So some food for thought here as, are we seeing everything we should be seeing when using these kind of techniques? So in conclusion, iterative reconstruction methods are available on all modern scanners, as I showed you earlier. Adoption and implementation varies depending on facility. Faster computational speeds will make model-based iterative reconstruction more practical to use, and already the computation times are coming down. Radiologist adoption due to different image quality and confidence level varies depending on experience and training. Thank you very much.
Open up for that amazing talk on the iterative reconstruction, but also sharing some of the pearls of the limitations and challenges that exist with the application of iterative reconstructions. So I will give the next talk, which is intravenous and oral contrast media considerations with new CT scanners. These are my disclosures. Now, we all know in this audience that contrast media is extremely important for almost all applications in the body, especially vascular imaging, tumor imaging. Cardiac imaging is a perfect poster child where CT has caused so much disruption in the healthcare. And this is possible not only in advances in CT, but also safe contrast media and power injectors that are available. And our focus with CT, with all our protocol developments, are to get the maximum contrast to noise for lesion to background to make the diagnosis easier. Now, that also holds true for using enteric contrast media. Historically, when we started using CT, we gave positive oral contrast media so we can see bowel structures, but later on we learned that it also allowed us to minimize our false positives and false negatives. Over time, as our need expanded, as CT penetrated for new applications, newer type of contrast, neutral contrast media were introduced that allowed us to look at bowel wall and mucosa better, and it's not surprising that CT enterography has become a desired modality of choice for evaluation of Crohn's disease or for various bowel pathologies. And also we have negative or air-based contrast media we use conventionally for CT colonography. Now, most of our protocols have been based on 120 or 140 kVp when these contrast media were introduced for application in CT. Now, what we have learned is the relationship of these higher atomic number material like barium and iodine, which are used as contrast media with kVp. At low kVp, the attenuation of these high atomic number material is substantially higher than what we get at conventional 120 kVp images. Here you can see at 140 kVp oral contrast media exam, high density material. At 100 kVp, there is a lot of streak artifact. Clearly, it's a concern because that alters image quality, but also might mask some of the pathologies. Another concerns that comes with higher atomic, high density material is when we are using automatic tube current modulation, the modulation is based on the attenuation of the tissue, and high density oral contrast media increases that, potentially adding about 5% of extra radiation dose for the patient. Now, we have been using low kVp imaging preferentially for radiation dose reduction, but we also learned that low kVp imaging is beneficial for increasing the attenuation of iodine, especially for vascular imaging. And we know that if you go from 140 kVp to 80 kVp, the attenuation of iodine can increase by twice. That gives an opportunity to improve the quality of CT angiography exams or reduce iodine dose for these indications. Now, what has happened in the recent past, as we have introduced modern scanners, these scanners have better tube performance. They have software that enable more optimal kVp selection. They have a better iterative reconstruction techniques, and that has led to increased utilization of low kVp imaging for routine scanning. Now, this is the data from MGH we put together. We looked at from 2000 to 2016, and what we noticed in 2000, a fraction of our exams were done, less than 5% were done using low kVp. Majority were done using 140 kVp. That was the standard of care. In 2016, we noticed that 25% of routine exams are done with low kVp. Hardly we use 140 kVp, maybe in some large patient, and 120 kVp is used in majority of patients. Now, when we look at the new scanners, only the data from new scanners, 80% of exams on these scanners are done with low kVp, and that is an important information to keep in mind as we design protocols. Now, we heard from previous talk from Christopher Becker that, dual energy CT, the clinical benefits it offers and how there is increased adoption, especially in last few years as the workflow has improved. Dual energy CT is being applied for a variety of clinical applications in different body parts. But when you look at the benefits of dual energy CT, one thing that stands out is the monochromatic image series, especially those at the lower energy spectrum. Again, they give you 2 to 3 times higher iodine attenuation for the same amount of iodine dose once you move to KEV anywhere from 40 to 60 in comparison to 120 kVp exam. So clearly, these are some of the changes that we encountered. And when you apply the dual energy CT for oral contrast media, you encounter the same problem. At the lower KEV spectrum, anywhere from 40 to 60, the attenuation for the same amount of iodine or barium gives rise to streaking artifact. You lose the benefit of contrast. It might mask smaller structures. The mucosa and the bowel wall details can be masked. So clearly, with that in mind, we have to design the protocols that will serve our purpose, but also we can exploit the benefits of contrast media. Now, there might few who might question if the contrast media is needed. I can imagine in the emergency room where the workflow is the primary consideration and oral contrast media might not add as much. But for a lot of other indications, especially for majority of oncology exam, for post-op application, iodinated or any positive oral contrast media is desired. Actually, in patients who have major surgery, like in this case, where we notice there is oral contrast media that we give preferentially in our practice, we see a high density material. This patient was scanned using dual energy CT. Now the question is this iodine? That means there is bowel leak. Is this hemorrhage or an abscess because there is an air fluid level? It is difficult on a conventional CT. On a material density iodine images, that area, that fluid turns bright. That means it's iodine. And on a virtual unenhanced image, it turns dark. It becomes easier to detect a complication like bowel leak on these dual energy CT images. So my point being, oral contrast media will become even more valuable for these type of complicated exams as we use dual energy CT in practice. With that background, what we learn is, okay, with 100 kVp, if we move from 120 for CT angiography, we gain more than 20% in attenuation. Potentially that can translate in less than reducing iodine dose by more than 20%. If you go to 80 kVp, your attenuation increases by more than 50%. Clearly, at the least 30% of iodine you can reduce. And if you are using dual energy CT and lower monochromatic images from 40 to 60 kV, the attenuation gain is 2 to 3 times higher. Clearly, that leads to an opportunity to reduce iodine dose by more than 50%. Now, if you want to do that, you have to follow a basic principle. that your injection duration should be preserved for 20 to 25 seconds, so there is more homogeneity in the vascular opacification. And if you drop your injection rate less than 3 cc's, then there might be more heterogeneous opacification, or one might miss the bolus. So around 3 ml per second injection rate is desired. So with that background, we asked 2 questions. First is, what is the real impact of the X-ray energy, whether we use low kVp or kVb, on the attenuation of IV on oral contrast media, so we can design our protocols and then understand what is the optimal concentration that we use, or the dose for IV contrast media we can use for CT angiography exam as we move to low energy scanning. So to answer these questions, we designed a phantom experiment. We used a colon phantom, and the phantom was filled with various contrast media of different concentration. We had like the iodinated 2 types of contrast media. We had barium. We had full concentration, then we dropped by 25% each. We scanned using 120 kVp and then went down to low kVp. We also scanned using dual energy CT. We processed images at low and medium keV images, and we evaluated this data for attenuation changes with low kVp. Now, these graphs demonstrate one simple point, that for the same concentration, if you move from 120 kVp, which is standard of care, to 100 kVp, you get 25% increase in attenuation. And if you go to 80 kVp, you get around 80% increase in attenuation. Now, the same data on dual energy CT tells you that you get 2 to 3 times higher attenuation as you go from anywhere from at 60 kV, you get about 2 times, and at 40 kV, you get 3 times higher attenuation. So what does it mean? How do we examine our protocols, oral contrast media protocols? So this is the protocol. If you're using 120 kVp, a standard concentration of different contrast media, barium or iodinated contrast media, if you use 100 kVp, you have to drop your iodine dose by at least 25% to get even higher attenuation, not even same. And if you're using monochromatic images, the 60 kV, you have to drop the iodine dose by 50% to get slightly better contrast and also a good CNR. So that is the ratio that comes once you design the protocols. So just to show you example here, this is a phantom data images scanned with 120 kVp, 100 kVp, and 80 kVp with the different concentration of contrast media and different types of contrast media, and you can see there is no significant differences in the image quality or the contrast, even despite dropping the concentration of contrast media by exploiting the low kVp imaging. And this is a comparative image from a dual energy CT data set that if you use 50 kV, even 25%, 75% dilution can give you equivalent amount of density and concentration, contrast. So we take that data and apply now to intravenous contrast media administration. For this, we do 2-phase trial. For phase 1, we dropped the iodine dose by 30% in patients who had a AAA studies. Their prior exam was standard of care, 120 kVp, and the follow-up exam was done by 30% dose reduction. And what we notice here is that we get a great image quality with 30% dose reduction, and quantitatively, there was more than 180% increase in attenuation, and the CNR also was very high, despite 30% dose reduction. And I'm sharing you some images, and as you can see, the images meet the diagnostic expectations. So based on what we learned, that despite 30% reduction, there is a substantial gain in the attenuation in CNR. We did a second trial, and then for this trial, we studied about 80 patients who had initial standard of care exam using a single energy CT. We did a follow-up CT using 50% iodine dose reduction. That means 16 grams of iodine. And here you notice that subjectively, all the exams met the diagnostic expectations. The attenuation was more than 100% higher at lower kV, and the CNR was also very high despite 50% dose reduction. Now, these are the images so that you can make your own decision. We have a comparison, a standard 120 kVp images, chronal for a AAA studies. This is a 50% dose reduction, and you can see the lumen opacification, the consistency in opacification, as well as the stent patency very well. These are another 3 different patients where you can see there is presence of endo leak, a small leak in this middle patient, and also a tiny leak here, and you can see consistently with these 50% dose reduction exam by exploiting the monochromatic images. Now, if you don't have dual energy CT, if you have single energy CT, you can certainly use the low kVp, like 80 kVp images in this patient who had EGFR of 33, and here we used only 60 ml of contrast, that is 22 grams, and you can look at the image quality. It meets the diagnostic expectation, and in the enhancement is pretty consistent because we modify our injection rate by meeting the injection duration of 25 seconds. Now, as we see more application of dual energy CT, one challenge that occurs is when you do material separation, the IV contrast and oral contrast are both extracted. Like here, we have oral contrast and IV contrast. On the iodine images, we will have both of them together, but on water images, both are extracted. So we lose that benefit. So it is desirable that we have new contrast media, which are of a different atomic number, so we can selectively extract one material for benefit of better bowel opacification. And as we heard from Christoph's talk earlier, tungsten, tantalum, and bismuth are being explored as oral contrast media material, and as you can see here, you can selectively extract the oral contrast, and you can leave the IV contrast behind. That will allow a virtual bowel cleansing and better assessment of the mucosal and mural details, which is desirable to assess bowel pathology, especially for ischemia, inflammation, and subtle tumors. Now, there are a few unknowns. First of all is the healthcare economics will dictate a lot, especially when there is demand for lowering cost. Maybe certain practices will move away from oral contrast media. As there is more consolidation in healthcare, it will demand more consistency in our protocols, and any challenges of changing concentration or doses might create a bottlenecks for workflow. Patient preference, what they want, will dictate what we give it to them. Also, as we see evolution of artificial intelligence and other algorithms, maybe we might not need oral contrast media at all. So we need to wait for all these development with optimism. So in summary, I think oral contrast media, I personally believe, is extremely important, and its role will grow. But if we use the low kVp imaging, we can easily drop the concentration by 25 to 50%. And there is also opportunity for new oral contrast media. For the IV contrast media, again, we can drop the dose anywhere from 20 to 50%, depending on if you are using a low kVp or KEV images. But if you are using a lower than 20 grams of iodine, it is desirable to preserve your injection duration to 25 seconds by modifying the injection rate. And this also creates opportunity to create ultra-low dose protocol that might benefit patients who have high risk for contrast media-induced nephropathy. With that, I want to thank you for your kind attention. And for the next talk, I want to invite Matt Davenport from University of Michigan. On the title of his talk is Steroid Preps, New Data, Motivating New.
Hey guys. Hello everyone. Last talk here of the morning or the afternoon session before the break. Disclosures. I'm going to talk about why we give steroid preps and what the evidence base is for that. You may hear people say, do those things actually work? Why do we give them? I'm going to show you the evidence base behind it and then show you where we're moving now in regards to the ACR manual on contrast media and what the new guidelines are saying as of 2017. This study here kicked it all off. This is a Lasser paper from 1987. It's a landmark prospective randomized trial published in the New England Journal of Medicine. There were approximately 7,000 subjects. And the patients got 2-dose methylprednisolone 12 and 2 hours before contrast or placebo. And those that got steroids had less immediate adverse events of all severity. The patients that they enrolled were average risk patients. So it would be like if everybody in this room were going to go get an IVP, you would be enrolled. They were not high-risk patients. They also tested a single dose of steroids 2 hours before contrast, and that did not work. So if your ER ever says, can't we just give them a dose of prednisone and scan them, you can say yes, but that doesn't do anything. The number needed to treat to prevent one event in normal risk patients was 34. Now, this study was using high osmolar contrast media, which obviously we don't use for intravascular administration anymore. They repeated the same kind of study design in 1994, also a randomized trial, but you can see there's only 1,200 subjects that they included. And they found, again, that 2-dose steroids, 12 and 2 hours before contrast, decreased aggregate and mild immediate adverse events in normal risk patients. Again, these are average risk patients that were included, not high-risk patients. These are the data from that study. One of the columns says steroids, one of the columns says placebo, and on the rows are the different kinds of reactions. So if you got steroids, you had a 65% risk reduction for any kind of reaction. If you got steroids, you had an 89% risk reduction for having a mild reaction like hives. Grade 2 and grade 3 reactions were not statistically significant. You can use these numbers to calculate numbers needed to treat, about 32 to prevent any reaction, 58 to prevent a grade 1 reaction, and of course we have no idea about the grade 2 and grade 3 reactions. Now you can notice here they don't call these mild, moderate, and severe, and they don't call them allergic-like reactions, they just call them grade 1, 2, and 3, and that's because they lumped a bunch of things together. Physiologic and allergic type reactions were put in the same basket. So this study has some weaknesses. Even though it's using modern contrast agent like we use today, they tested average risk patients. It was designed for 6,000 subjects, but they ran out of money, so it's underpowered for moderate and severe reactions, and they lumped some things together that probably shouldn't be lumped. The main argument against steroid preps is we have no level 1 evidence that if you give someone who's high risk a steroid prep, that their risk of dying or having anaphylaxis goes down. We just don't have that data. So giving a steroid prep is based on extrapolated evidence from the HOCM study and assuming that the trends present in this study would have held up had they had enough patients to test. So we give preps to prevent allergic-like reactions, and in doing so we make an already uncommon event rarer. We don't make the risk 0 because it doesn't always work. Some patients have breakthrough reactions, as you probably know. So how many patients need a prep to save one life? Now, we don't really know the answer to that question, as I just said to you a second ago, but based on the best available evidence, you can try to model that. This is a study from 2015 by Ben Mervak, who studied approximately 1,000 subjects who had received a steroid prep. And the reaction rates that those patients experienced were benchmarked against the literature. And all the patients in this paper who had received a steroid prep obviously had risk factors to get that steroid prep in the first place. They weren't average risk patients. In those who specifically were pre-medicated because they had a prior contrast reaction, the number needed to treat to prevent one reaction was 69 for a reaction of any severity. And in this case, the reaction we're preventing, again, is an allergic-like reaction. But really, do we care that much about preventing Mrs. Jones from having 3 hives? Probably not that much. What we really care about is whether Mrs. Jones is going to develop a severe reaction that requires significant treatment. So we can break this data out further to say, okay, the number needed to treat is 69 for any reaction, but to prevent a severe reaction, the number needed to treat is approximately 570, and you can see the confidence estimates there are between 390 and 1080. And to prevent a lethal reaction requires around 57,000 based on best available evidence. So if Mrs. Jones came to you and you were saying, Mrs. Jones, you need a steroid prep because you had hives before, and she said, what's the likelihood that this is going to help me? If you were being honest, you'd say, well, not very likely, actually. You can also say how much time is required for all these preps to occur before you actually save somebody's life. And to prevent a lethal contrast reaction, it takes about 80 years of cumulative premedication, like if you stacked them all up next to each other. So many preps are required to prevent one reaction, and most patients receive no personal benefit. So if you are an outpatient and you're just at home watching TV and every few hours or so you take a prednisone dose that costs a couple cents, you may not care that much, but if you are in a high-risk environment like the ED or you are an inpatient and you're making them wait for 13 hours, there may be some harm there. Prepping takes a really long time, so is it worth it? This is a study of inpatients where you had patients who were prepped, about 1,400, and compared to patients who were not prepped, about 1,400. They were matched by age, sex, and year of CT, and they had similar rates of 13 major comorbidities. What this study showed is that premedicated inpatients had a significant delay to the time of imaging. So if you got a 13-hour prep, it took you on median 25 hours longer before you finally got your scan. That's not surprising because they had to wait for the prep to happen. But interestingly, they also had a significantly longer hospital length of stay. So it wasn't like the prep was taking up time that would have otherwise been spent getting other things like IV fluids or antibiotics or whatever. It actually frame shifted their entire hospitalization forward by 25 hours. They also had significantly more hospital-acquired infections, and they spent more money during their hospital stay. So does prepping inpatients hurt more than it helps? That's a reasonable question. This is a hypothetical cohort analysis based on best available evidence. As I pointed out to you, the level of evidence, of course, is not strong, but this is our best estimates. To prevent a reaction of any severity requires 72 additional hospital days, $159,000 additional dollars spent, and contributes 0.04 additional deaths due to that waiting. To prevent a lethal contrast reaction, which is really what we're all about trying to do, takes 162 more years of premedication, and you get to spend $131 million, and in the process you kill 32 additional patients. So in the process of saving that one patient's life, you end up hurting a whole bunch of extra patients from the collateral harm. Now, all models are interesting and some are useful, but they could be rosy estimates. So let's assume the best case in all of the evidence that we have. Let's assume that the PrEP efficacy is the most. Let's assume that the harms are the least based on all those confidence intervals. We can model that also. This is the best case scenario, assuming all variables, and to prevent a lethal contrast reaction, giving inpatients 13-hour steroid preps still kills 3 times as many people as you save by doing that. So prepping takes a long time. Let's just speed it up. Maybe the problem is it takes too long. What is the evidence base for a rapid prep? You probably get asked about this all the time. Until this year, there was one case series with 10 subjects of giving people random IV doses, and they did or didn't have reactions. But now we have some better data. This is a study that came out this year, again by Ben Mervak. This was a non-inferiority study. The non-inferiority margin was 4%. There were 1,000 subjects that got a 13-hour prep and 370 subjects who had an accelerated prep. The breakthrough reaction rates were non-inferior, meaning if you gave someone a 5-hour IV prep, it was not statistically different from a 13-hour oral prep. So if you were an ED patient or an inpatient, you would be much more motivated to get a 5-hour prep if you had to get anything at all. These are secondary analyses from that data, basically showing the same thing. The primary outcome measure is that prior reaction to iodine-based contrast material, that second line there. One of the other interesting things from every time we look at this, if you get prepped for some other reason, asthma, multiple medication allergies, bee stings, whatever, some other stuff, your breakthrough reaction rate is always 0 in all of the studies that have ever looked at this. So either preps are amazingly effective in that cohort, or there's probably no reason to prep those patients. So a 5-hour intention to treat rapid IV prep is non-inferior to a 13-hour oral prep. That's good news. These data have led to changes in the ACR guidelines for inpatients and ED patients. So what do the policy statements say? First, I'm going to start with Europe and then go to US. The ESUR says for patients at increased risk of a reaction, consider the use of premedication. So it's not mandatory. Clinical evidence of the effectiveness of premedication is limited, and if it's used, give the 12 and 2-hour dose, which is not used as commonly in the United States. Risk factors for acute reactions listed in the ESUR's manual are prior moderate or severe reactions to the same class of agent. Notice they do not include mild reactions. Asthma, allergy requiring medical treatment, which is not commonly treated for in the United States, And of course, if someone were to give you intravascular high osmolar contrast media, which I don't recommend. Now, the old text in the ACR manual said the primary indication for premedication is pretreatment of at-risk patients who require contrast media. And you would probably wonder to yourself, what does that mean? Who are at risk? Give me the list. At risk was defined as having more risk. Okay, very helpful. So the new statement says this is the new text. This came out about 2 months ago. Accelerated IV premedication may be considered in the following settings, and I'm focusing just the attention here on the accelerated prep because that's what the change is based on. If you are an outpatient who has a prior reaction, who showed up for your contrast-enhanced study, who would be indicated to get a prep, and whose examination cannot be easily rescheduled, it suggests you could consider doing a 5-hour prep. If you're an emergency department or inpatient who is indicated to get a prep, you basically should be exchanging all your 13-hour oral preps for 5-hour preps. So here's the language specifically. We've now adopted the may be considered language, so it's not obligatory. If you want to make your own local policy, I'd encourage you to, of course, write that down and follow it, but it's sort of up to you now how you want to handle these cases. Some people say, I don't want to prep people who've had hives before. Well, it's, I guess, your discretion now. Just make sure you put it into your policy and follow it. And then emergency department and inpatients now, this is a fairly significant change. The 13-hour oral preps are being replaced by these 5-hour preps if we believe that prepping them is going to adversely delay care decisions or treatment, which is essentially everybody in the ED and inpatient settings. So at my hospital, we have wholly converted all inpatient and ED 13-hour preps into 5-hour preps. That has been received very well by our referring partners, and we anticipate this will have significant improvements in ED throughput time. In the past, we had patients actually getting admitted for steroid preps, which seems amazing, and hopefully that will stop happening. So in summary, a large number of patients must be pre-medicated to prevent one reaction of any severity, and to save a life requires probably around 50,000. And we can quibble about the numbers, whether it's 30,000 or 50,000 or 70,000. It's a large number of people. Pre-medicating inpatients is associated with substantial cost and harm that is likely greater than the benefits. Recent data have led to several changes in the ACR guidelines. First, preps are really only indicated for prior reactions to the same class of contrast media, which means that if you have an allergy to something else, it's not relevant for deciding whether to give someone a prep. Secondly, preps, in quotations now, may be considered, end quote. So if you want to make your own local policy to be more or less restrictive, you're sort of up to you. Just make sure you follow the rules in your own policy so when something bad happens, you can point to it. And third, if a prep is indicated, a 5-hour prep should be used instead of a 13-hour prep in inpatient and ED settings when prepping will, quote, adversely delay care decisions, end quote, which is basically always in those settings. Thank you very much.
Matt, I think now we are open for question and answer. Matt, you want to come back? And other faculty, Kalpana, Christoph? So I encourage, so please use the mic. Anyone who has a question, kindly.
Thank you for your great talk on contrast agents. And my question is, if you're giving lower concentration of oral contrast, does that mean your nurses are triaging patients according to size and determining what contrast to give them at that time, or do you just give it to everybody and then make a decision on what KV to use once they reach the scanner?
I think that's a great question. Those who haven't heard the question is, if you are changing the contrast media concentration based on patient, KVP, and are you also considering the body weight? Is there a triage mechanism to use different protocols? So that's very difficult in a busy CT. So what we are doing is based off what we have studied and looked at our low KVP imaging, how many times we are using. We have just moved to 25% reduction in our iodine dose, so we are using a less concentration, but not 50%, just 25% lower dose. After we have trialed it initially, we did a clinical trial because most of our patients are now being done with low KVP. So this is only in one area where we have new scanners, everyone is getting the new oral contrast media. But in off-campus, we haven't introduced that yet. So we are still exploring it, how to make it happen. Workflow will be challenged because you can imagine, if we gave like only 75% of the total and patient is 300 pounds or something, that amount of iodine might be too less. So some patient might be negatively affected. So we are cautiously introducing this only in certain scanners where there are, auto KVP type of app there, and we are using low KVP preferentially in those patients. So only 25% reduction so far. But IV contrast, yes, there we are using it for all low KVP scanning or for dual energy CT. CT angiograms, we have dropped our iodine dose routinely by 30%, and in high-risk patient, we give like 12 to 15 grams of iodine, which is like 50 to 70% lower dose. There we are using it in every patient.
Just a question for Dr. Davenport. Your protocols for inpatients, you do not appear to distinguish between low risk mild contrast reaction, severe contrast reaction. So you prepping whether they had hives or a serious anaphylactic reaction? Or?
Yeah, thanks for your question. The question, in case you didn't hear it, was do we pre-medicate for all prior severities within a class? And the answer is yes. So at our hospital, if the person's had a mild, moderate, or severe allergic light contrast reaction, the same kind of agent, then we pre-medicate for those patients. I think it's reasonable to have a difference of opinion about that, so I don't feel super strongly about one way or the other, but that's what we do at our hospital.
Thanks.
That was my question. Do you pre-medicate hives?
Yes.
So, Matt, thank you for the talk. My question is it's tough to change protocols in practices. So do you have any advice for practices on how to adopt some of these new recommendations or new guidelines or new areas of uncertainty where there's latitude to change the, long-standing traditions of how we've been doing things?
That's a great question. How do you essentially exercise change across a massive organization when you have lots of parties who order contrast? So the way we are doing it, number one, we have an order set within our Epic system so that when someone has an allergy flag that pops up for that kind of agent, it'll route them to be able to click the button that automatically orders the kind of steroid prep we want them to order in the ED and inpatient environments. That can help a lot. We also are doing a propaganda campaign, so we're sending out different pieces of information every possible place that we think it would be appropriate, and we're working through the Office of Clinical Affairs to do that. Simultaneously, with the steroid prep change, we're also making changes to how we do EGFR-based screening, which you'll hear more about probably on Tuesday during the Gadolinium Symposium. And so that also has required the same kind of change agency to make sure people understand what's going on.
You have a question?
Yeah, I have a question actually about, I was wondering how the iterative reconstruction would affect texture analysis. If you were doing texture analysis and if you're using different algorithms, is that going to mess up your data?
That's a good question. We are actually doing a study to look at that right now. I don't have any preliminary data, but I think since every vendor is doing things a little differently, it will affect the way the texture of the noise looks as well. I couldn't tell you exactly what it is for each of them. A lot of what's happening in the iterative recon process is proprietary for the vendor, so unless you're doing some of your own analysis using phantoms, you couldn't come up with any conclusions. And hopefully we'll have some good conclusions from the study we are doing.
I have a question for Christoph. Christoph, you presented a nice overview on the evolution of CT and projected what might happen in the future, especially with the artificial intelligence and some other improvements in health IT and automation. Do you think we will be moving more towards quantitative imaging in like 10 years, 20 years from now, rather than the subjective assessment we do right now? Everything will be quantitative?
Well, I'm pretty sure that AI will affect our daily work in CT substantially within the next couple of even years, I would think. I have seen, as I showed here, that vendors are working on trying to improve the workflow, not only in the way as I showed it here with just applying AI to a 3D workstation, but also to what makes perfect sense, trying to find feedback mechanisms in analyzing image quality after they have been produced by a CT scanner, and then brings this back to the machine and kind of like trying to automate the process of improving quality that comes out of a CT machine. So there's lots of things going on that make perfect sense, and they will for sure come up on the side of scanning and workflow, but also on the side of image interpretation. Such as like, I'm very much involved in the tumor response assessment, and have been recently approached by a company that tries to automate the analysis of image data in terms of trying to detect tumor and tumor burden. And I mean, it makes perfect sense. What the computer certainly can do quite well is compare two data sets that are pretty similar, but just different in the extent of tumor burden that is presented at one or the other time point. So it's highly likely to believe that at least we are being supported by AI in very many aspects, actually, in the future.
Great. Matt, what is your policy regarding severe contrast reactions? Do you guys pre-medicate and like have anesthesia standby? What is the policy in those cases?
So I believe the question was, if someone's had a prior severe, like I almost died reaction, and they need to give them a contrast enhanced study again, what do you do? Our general approach to those patients is to really find another way to answer the question. There are very few things that really require the exact same kind of contrast agent again, and we find ways around that problem. Switch to MR if it's a CT problem and vice versa. But if your back is up against the wall and there is literally no other option, and it's absolutely life-threatening and critical that you get the diagnosis correct, then have people there who know what they're doing to treat the reaction, like anesthesia and someone with an EpiPen. But in general, I would strongly encourage you to not inject those patients because I think it's just not, the safety margin's not great for that.
Great. Are there any other questions? Kalpana, at your place, you mentioned that, you know, MBIR you are using in about 30% of patients?
Right, yes.
And how do you pick those patients?
We have a criteria. I think it also depends on the radiologist who's ordering the exam, whether we want to use VEO in our case for GE or not. But some of the cases where we would like to use it is, frequent flyer patients, if they're getting a lot of imaging and we want to try and reduce their dose. We want to use MBIR without, and it's not a stat exam because time is a big factor. I know that our ED folks actually want us to use MBIR for some of the ED patients that we get, and they don't mind waiting for the computational time. Pregnant patient would be one criteria. You could, if it's not urgent and you can take your time, maybe younger patients who are getting PE and things like that, where you're worried about organ dose, using MBIR would be a good idea. But I think a lot of what drives the practice is who's ordering, how much are your radiologists into ordering the MBIR part of it. I know that for our I'm just going to pick on body imaging section, not everyone orders the VEO. So if you really believe in that and you're used to reading that, I think you'd order it, but maybe you won't add it on. So that's why I think adoption has been a little slow. It's improved significantly since we first got it, but I still think it's a ways. Definitely won't call it 100% for all the patients, not possible unless the computation times come down. But it's slowly improving.
Got it. So there's a question, John?
Dr. Davenport, it's from your presentation, it sounds like nobody should be giving pre-medication. Why is this, am I interpreting that correctly?
So I believe what you said was from your presentation, it seems like nobody should be giving pre-medication. I think that is a very difficult question, actually, because I think if you were to ask a patient, they would say that they want it still. I think it's still the standard of care in the United States to do it. I think the risk of giving a short-term steroid regimen in the hospital or a longer-term steroid regimen as an outpatient is associated with very little risk. I think giving a 13-hour oral prep as an inpatient or ED patient is associated with significant risk. I think we're moving towards a time where steroid preps are going to become less common, but it's not that they don't work, it's just that they don't work that well. And so that's why I think it's reasonable to have differences of opinion about this. I think you could look at the exact same data and draw an opposite conclusion to what I just said. I think you could look at the data and say reasonably, it doesn't look like, it seems like you have to give tons and tons of preps to get any benefit at all, so I'm just not motivated, I'm gonna wait for something to happen and treat with an EpiPen. I think that is not necessarily wrong. But I think currently the standard of care is what it is. My assessment of the best available data is it probably does have some effect, albeit small. And that we've reached where we are right now at our hospital as this sort of happy-ish medium of where we think we are, but I think reasonable people can disagree about that. And I think that's why we included the may be considered language in the manual, rather. What's your opinion?
I don't give it. I don't use pre-medications, but I'm in an outpatient imaging center, so when somebody shows up at our doorstep who has had allergic reaction, then we just take an EpiPen and we have a doctor who sits next to the scanner, but we stopped giving it.
Wow. Yeah, it's interesting. It would not surprise me if more people started to do that. What I would say is that if that person were to have a reaction and the policy said one thing and something else was being done, it could expose you potentially to liability. What does your policy say?
Our policy is that we don't give it, but the physician can do what they want. So that's an individual physician's decision to override the institutional policy.
That's interesting. I would encourage you to publish that when after you've had an experience with that.
Matt, did you receive any, at your place, pushback or any challenges of introducing the abbreviated PrEP in off-campus imaging where there are less resources in case of a problem? I can imagine in the main campus where, if there are any problems, you can handle it. But off-campus, was there any issue in introducing its short policy?
So the rapid PrEP for us primarily is being applied to inpatients and ED patients, so that's less of an issue. The second thing is that we have this policy where if someone's getting a PrEP, this is long-standing from a long, long time ago, not connected to this, that those patients get scanned at the main hospital by default. So I can't really answer your question in a way that you want me to. But in terms of the clinical people, I mean, they are thrilled with this. I think if they had their druthers, they'd do what the gentleman there said, is just forget about all this stuff. So they're happy that we're doing the 5-hour version in the ED and inpatient setting.
Great. If there are no other questions, I think we can end this session early, and we can come back at 3:15 for the next session. But I want to thank our speakers for amazing talk and for the audience for their participation.
For over 20 years, Meetings by Mail has provided the gold standard in enduring materials CME. With courses specializing in body imaging, breast imaging, vascular ultrasound, nuclear medicine, and echocardiography, our activities can meet your entire self-assessment CME requirement for maintenance of certification. We collaborate with renowned institutions such as the SCBTMR, Duke Radiology, Penn Radiology, Cleveland Clinic, and many more in order to create high-quality content for the home viewer. Products are available in DVD-ROM format and new this year, streaming online. 400 fully accredited hours of CME are available for your review. Presentation topics are searchable by session, faculty presenter, and keyword search. All video has optimal image clarity with audio cued to every slide. Bookmarking ability allows you to leave the activity and resume seamlessly regardless of device. We have incorporated all CME applications so you can get your certificate immediately after completing an activity. So if you can't make the meeting, bring it to you. Meetings-by-mail.com. Try Meetings by Mail and make sure you're never too busy to learn.
And the panelists, if they could come forward and sit down on the podium, please. And I'm also waiting for Michael Federley. Here, good, so we can get started. I'm Rudy Töney, and I'm the moderator overall of this session of abdominal and bowel imaging. And the first session is a debate, CT versus MRI for IBD. And Dr. Michael Federle from Stanford will be moderating this session.
All by myself?
Huh? I am coming afterwards.
I just got here. I haven't even put on a shirt and tie yet. Okay, well, this will be interesting. I have literally just arrived here like an hour ago from another meeting, and my voice sounds like this because over the last 48 hours I gave 16 hours worth of lectures. So I basically don't even know what time zone I'm in right now. Okay, so we need to get started. Who's going to think? We're going to start with CT enterography,
Yep.
I believe.
Usually the losing part of the debate goes first, so I will continue that tradition. So this is going to be a debate, but don't expect a lot of physical blows and things like that. And we'd have to have a debate that really strike passion, like political or sports, or debate academics versus private practice, or it's where we are here now, country music versus rock, or if you're a fan of commercials about beer from 20 years ago, perhaps we debate tastes great or less filling. So we're not going to do any of that, but you know, there is still some value to discussing kind of the old staid CT enterography. It's been around a long time. You're either probably doing it in your practice or not. And let's not forget, 20 years ago, there could have been a debate between doing CT for the small bowel versus small bowel follow-through, because many of us, if we're old enough, like myself, our image when we prepared for boards was this was what the small bowel looked like. And for many people, clinicians and even patients now, they've learned that this is the way their small bowel might look like on cross-sectional imaging. So I don't want to downplay the value that CT enterography has kind of provided to the field of radiology, and in many ways led to the advances in MRE that we are going to hear about shortly. And so we've learned that we can evaluate the small bowel very well with an appropriate oral contrast prep, and we can identify things that look abnormal to us and what they might mean. We also learned quickly as radiologists that we like axial images, but clinicians and patients don't. And so for some of us in the early days of CT enterography that labored showing images like this, no one cared, and then you gave them an image like this, and all of a sudden everyone said, oh, now I can see the area of active inflammation. And so I think we learned a lot about, you know, how to present images to our clinicians and therefore to our patients. We certainly know from a vast amount of data on CT enterography, we can find areas of active inflammation and active involvement by looking at the bowel wall and the vessels that supply those areas. And we can see all the things that we're used to seeing on, you know, small bowel studies, such as looking for disease at the anastomoses. And you can see the anastomoses, of course, very easily when you remove the bright contrast, you know, from your field of view and use a lower attenuation oral contrast agent. And all the things we know about that we should see from GI studies for years and years, we should see with CT or MR, and we should be able to find multiple skip lesions, and we can find 5, 6, 7 skip lesions in many cases, no problem. One of the benefits we learned is that we're saying we are doing a small bowel study to look at IBD and inflammation, but we learned quite quickly with a good prep and the right contrast and waiting just a little bit longer, we can also get a great study of the colon in many cases. And this was often a shock to our gastroenterologists in the early days because they kind of figured we were tailoring something to the small bowel and designing something that would just stop at the terminal ileum. But in fact, we got great looks at the colon, and here's an involvement, of course, that's no problem, very easy to see, of significant disease here in the right colon. And so therefore, CT can obviously help us for looking disease in this area. So the good news, if you want to be an advocate for CT enterography, even though you're going to lose the debate, is you're going to want to talk about how simple CT can be, how quick the scans are, how widely available CT is. CT is expensive, but in this area, CT is less expensive than MR, and that may have implications when the MR can't get approved by the patient's insurance agent. The clinicians are very comfortable with CT images, maybe too comfortable, and we also have the ability to kind of do everybody. And so our gastroenterologists refer a lot of patients to us that go a little beyond the spectrum of known IBD and follow-up study, as I'll demonstrate shortly. So in the time it takes to read this very unfunny joke slide, we could have done your entire CAT scan. That is not true for MRE. And so we should not overlook the value of CT, that it is very simple. Most times we don't need anesthesia. Most times we don't need two fellows standing at the scanner to make sure it gets done correctly. Most time we're not worried about bowel artifacts. Do we ever mess up a CT enterography? Every day. And I usually blame my fellows and junior faculty that are sitting out there. We could mess them up, but I think it's more reproducible because we have a longer kind of experience with CT enterography. It's a more mature technology right now. And sometimes we do patients where the history is, I don't think they have IBD, but maybe they have something else. I don't really know. Can you scan them? MR is probably not going to have time to be able to get approval for those. And we many times find unexpected findings on CT enterography, kind of our own personal area of incidental-omas. And so very dramatic findings you can see in people sometimes with very minimal symptoms, and sometimes you can pick up kind of unusual things like this small carcinoid tumor in the wall of the small bowel here that might be explaining the patient's symptoms that weren't altogether evident. So although the focus of this is inflammatory bowel disease, I want to point out that CT enterography, because it's simple and easy to apply, and you can do 20 or 25 of them in a day if you have that many referrals from your gastroenterologists and local clinicians, may still have value. The less than great news if you're going to defend CT enterography, we require IV contrast. We require radiation, and that's something that's going to be evident, I'm sure, in our MRE presentation. MRE is newer, and it's better, whatever those things mean. Of course, what is your patient population? If you're a pediatric radiologist, you're going to be a more staunch defender of MR enterography. If you're transitioning to young adults or therapy monitoring, you may still be an MR enterography. There's, of course, a bimodal age peak to inflammatory bowel disease, and maybe that's a little bit lesser of a concern in the second age peak for IBD. And then, of course, this is very important. Known IBDs might be where MR enterography is living, highly suspected, maybe. Possible IBD, that's probably coming to CT enterography. And CT enterography is happy to take all the IBS bloatings, nausea, don't feel well, think I have something. Can you please look for my referral from gastroenterology? And so this is an area I think where CT enterography has a real benefit. MRE has also forced CTE to improve. It's forced us to reduce radiation dose, be better at fistulas, better at perianal disease, and better at looking at activity and fibrosis. Maybe not better than MRE, obviously, but have improved greatly. This is just a slide from one of my colleagues sitting out in the audience showing we used to give a lot more radiation back in the early days, and now we give a lot less. We can find perianal disease, and we might want to play with dual energy CT in the bowel and make our exams more complicated, maybe look more like MREs in the future. So just in summary, MRE is great. MRE is better. I don't know what that means, but I'm going to say it's better. Having said both of those, you will still do many CTEs in your practice, and I would bet most of you will still do more CTEs in your practice, and someone out there is going, hey, where's ultrasound's time in this whole debate? Thank you very much for your attention. I prevented your slides from being loaded.
Yeah, this is your.
That's how you win the
Dr.
debate.
Platts dropped the mic.
Sabotage.
I have sent his slides away. They're in Chattanooga.
I obviously knew that Dr. Platt was going to be a very difficult act to follow. Rather than trying to address him head on, which I knew I was going to lose, I racked my brain for a while to try to think of sort of an alternative strategy to try to distract you guys in the audience. And so my inspiration was our good SCBT president, Dushyant Sahani, and I tried to think if I were to put together a talk in Dushyant's shoes, how would I do it? And so this is actually ripped from an actual talk that Dushyant put together. I think it's something like everything I know about radiology I learned from my dog, Chip. So I thought that I could do something like this, but then I thought, well, it wouldn't be fair to Joel because I would, obviously the guy who shows the cute dog is going to win the debate, although he did show a cute cat for his CAT scan. And then secondly, there's no way in hell that Dushyant would ever advocate for MRI over CT. So So anyway, scrapped that strategy and decided to just kind of go my own way. The argument has already been laid out pretty clearly by Dr. Platt, and so I'll just be reiterating some of the things that he said. Obviously, the ionizing radiation risk associated with CT, particularly in the early 2010s, really led to a lot of concern among referring physicians, patients, their families, as well as radiologists. And so I highlight one study. Obviously the data having to do with CT risk associated with cancer is imperfect, based a lot on nuclear Holocaust survivors in Japan who got a one-time dose of radiation, nuclear workers in Eastern Europe who got lower doses, but again, not really mimicking the kinds of doses that patients who would get repeated CTs get. But that being said, the numbers of 75 to 100 millisieverts have been coming up repeatedly in studies. I highlight one study from Cork, Ireland, that looked at Crohn's disease patients over a 15-year time frame, admittedly in the late 90s and 2000s, and they showed that 16% of Crohn's disease patients exceeded 75 millisieverts in radiation over that 15-year period, and 80% of that exposure was from CT. And we know that patients who have Crohn's disease, because of the waxing and waning nature of the disease, are likely to receive radiation from multiple scans over the course of their lifetime. I highlight a few. Obviously, I cherry-picked some of these numbers. All of these numbers were basically meant to show that we're doing reduced dose CT, which is much lower than the numbers that I'm highlighting here, but I'm just showing you that these were the baseline effective doses from some of these studies, obviously from illustrious institutions such as the Cleveland Clinic, Seoul National University in Korea, and our own MGH, again showing that these effective doses are in the 5 to 10 millisievert range. So again, you can imagine a patient who has Crohn's disease getting a number of these scans over the course of their lifetime are going to get close to that 75 to 100 millisievert range that we were talking about. The main advantage of MRE obviously is the lack of ionizing radiation. It does have superior soft tissue contrast for characterizing bowel inflammation. And as Dr. Platt alluded to, because of the soft tissue contrast, we are able to assess the biliary tree and the anal sphincter complex at the same time while we're also looking at the small bowel. And I'm just highlighting two examples of perianal fistulae, or another case of a cholangiocarcinoma arising in the setting of PSC, things that we can see on MR enterography images while we're also looking at the small bowel. Again, because you don't have ionizing radiation, we can image the same part of the body repeated times. So I highlight some of our cinematic techniques we use, our balanced steady state free processions, where we can basically step through the small bowel. And I find that's really helpful for patients who don't take very good oral contrast. And you want to know, is that underdistended bowel abnormal, or is it just underdistended because the patient didn't take contrast? And the cinematic images, I think, are really helpful for that. Again, we can image the same bowel multiple time points after we give contrast. And so, again, as Dr. Platt alluded to in his talk, this progressive transmural and hyperenhancement of bowel is one of the common features that we attribute to active inflammation, and the fact that we can look at an enteric phase and look at interlayer stratified enhancement and then follow it over time and see transmural enhancement at the equilibrium phase is something that really increases our diagnostic certainty that there's active disease. We have T2 signal intensity that we can look for bowel edema, and diffusion-weighted imaging that we can do to also look at both restricted diffusion associated with active disease and fibrosis. Both CT and MR have been validated for extensively for Crohn's disease activity. I will say that MRE has been more extensively validated against mucosal healing, which is the latest and greatest gastroenterology biomarker of primary efficacy of biologic agents. And these were two papers, one from Jordi Ramola's group in Barcelona and a second paper from our group in MGH, really showing that if you can do serial MREs on patients early during the course of biologic therapy, that the MRE features do correlate well with mucosal healing. And this is the Maria Index score that many of you are familiar with, that was developed in Barcelona through logistic regression analysis that links different imaging features into a quantitative marker of activity. This is data that Avinash's group put together based on our experience at MGH, really just sort of highlighting, I think, what we already know, which is Over the last 10 years, there's been a shift in referral practice from CT to MR. And again, this is just showing that the total number of CTs and MRs on a per patient basis is basically staying the same over 10 years, but the number of CTs is dropping fairly dramatically and essentially replaced by MRs. So the total amount of cross-sectional imaging in this population is basically staying the same. Many of the disadvantages, again, that Joel highlighted in his talk, the main thing being the long scan times. I mean, 30 minutes at best. Most places, MREs are taking 45 minutes. The need for sedation or general anesthesia in young children or in adults who have neurologic issues. The evaluation of acutely ill patients, in the ER setting, can you even get an MRE in your emergency room after hours? If you can the patient even tolerate the oral contrast? If you think this patient has a perforation, are they really going to be able to take oral contrast, and do you even want them to? Can you detect free intraperitoneal air? All of these things that CT does much better. If you have to do an imaging study with IV contrast alone and no oral contrast because the patient might have to go to the OR, you'd much rather get a CT than an MRI. Similarly, susceptibility artifacts from air in the bowel that are much worse at 3T, and again, the potential risks of gadolinium contrast agents, which are going to be discussed in much more detail later on in this meeting. Again, I just highlight some of the problems with patients who don't take good oral contrast. Susceptibility, we talked about. Under distension, Joel talked about. And again, I also highlight that there's intrinsic T1 signal intensity from bowel contents in patients who have stagnant bowel that can also really limit your ability to look at the enhancement pattern on post-contrast images. I will say parenthetically that we are getting a lot better with our MR enterography protocols in terms of making them shorter and better tolerated by patients. Certainly at MGH and at a lot of institutions, we're dabbling with simultaneous multi-slice for our diffusion-weighted imaging. We're doing radial and other non-Cartesian case space acquisition techniques. The idea being you can either acquire your images faster, or you can allow patients to have imaging done free breathing so they don't have to suspend respiration. And both of those things are making MREs much more palatable for patients. So we're certainly not at the 2 seconds where we are with CT enterography, but we're getting closer every month, basically. So in summary, again, lack of ionizing radiation, I think, is the primary thing that makes MRE the preferred imaging modality in this population. And again, the soft tissue contrast is very helpful. But there are many limitations that we've discussed. And again, we're getting better, but we're certainly not nearly where we are with CT in terms of comfort and tolerance by patients. So thanks for your time.
All right, so I think we're ready for the discussion part, right? So let me ask you a question, Dr. G. Excuse my scratchy voice here. I'm not really breaking up with emotion yet, so that comes later in the day. So you talked about at the graph showing the decrease in utilization of CTE versus MRE at Mass General over the last 10 years. If I was looking at it, though, it's not as though CT has continued to drop down in the last few years. The way I would have read that would be it's sort of leveled off pretty much even with MR right now, which would suggest that you have found a role for both modalities. And before I actually saw that graph, I was writing myself a note that, having worked for the last, 25 years at major liver transplant centers, where we clearly have made a lot of advances in CT surveillance for HCC and simultaneous improvements in MR, and MR has some clear advantages, but we still maintain a very active role for both of those in our surveillance program. And I wonder if that's sort of the conclusion you're coming up with also in this Crohn's population.
Yeah, absolutely. I mean, I'll defer to Avinash as well, who's the senior author on that paper. I'm a pediatric radiologist. I do some adult abdominal imaging, and I advocate strongly for CT in our kids as the first imaging modality for a kid who is newly diagnosed. There's a lot of evidence that the length of involvement of disease plays a critical role into whether you triage these patients into primarily aggressive medical therapy or you think about surgery up front. And you can't, in many cases, you can't get that answer from an MRE in a patient who's never had an MRI before. So I feel very strongly about that, and I think we all, everyone in this room has contributed to the overall awareness of CT radiation and the decrease in the doses. The talks earlier talking about model-based iterative reconstruction have really alleviated a lot of the concerns. And so what we've certainly gone to is a model where first-time diagnosis, patient gets a CT, they go to MR for activity assessment after that. If they're urgently ill or you suspect a perforation, they typically come in for a CT with IV contrast alone. And we've found that that's been the right balance in terms of getting patients access, getting them the imaging that they can tolerate, but trying to keep the overall radiation down. Avinash, do you want to add to that?
Thank you, Mike. So the data which Mike showed actually shows the number of MR CT scans per patient. If you look on the whole, there has been over the 10 years, what we've seen is there has been a twofold increase in the imaging performed in Crohn's patients. That include both scanning of new patients as well as the same patients being scanned more because of surveillance. What we found was for MR, there was nearly a 10-fold increase in utilization, but the CT utilization remained stable.
Yeah.
So for example, CT was like, per year, if there were like 250 scans, it remained 250 at the end of 10 years. But MR, it jumped from 20 to 600. So there was a huge growth for MR, but CT remained the same. So what the data showed is that the utilization as CT is still there. Patients are still being scanned for CT angiography for patients who are acutely ill for detection of complications. Patients who are coming to the ER are still getting CT angiography. But MR is being more utilized for pediatric patients, for follow-up of patients, and also for surveillance and mainly for monitoring of treatment response, because a lot of these patients are getting newer therapies like the immunotherapies, and the MR helps evaluate those patients.
Joel, I was struck by one of the points you made that had occurred to me separately as well, and that is we scan some patients for rule out Crohn's who really turn out to have neuroendocrine tumors, the disease once known as carcinoid, and other things. We have found sprue with carcinoma or lymphoma as a complication where somebody thought they might be looking for Crohn's. We found GI bleeders where they were looking for Crohn's as the cause of GI bleeding, and it was really an AVM or something else. And maybe you want to...
Yeah, sir, I think I think the curves you've shown are great, and that curve works for known Crohn's, or we know Crohn's and we're going to treat it and follow it. The curve, if you were to quote anyone with a bowel problem, kind of just in a wastebasket coming in, I think would still show a lot of CTEs being done. That may change over time also, because we still have radiation and other things. And so I think your comments are absolutely right. I think we've seen in our practice CT enterography used very commonly as a referral tool from gastroenterologists and clinicians who have a variety of concerns, and some of them turn out to have Crohn's, but many of them, as you point out, have other things which are extremely important. And that kind of biofeedbacks back to the clinician that this is a way to feed these into the system. And frankly, if I found someone, my guess would be with unexpected sprue, and there's some new sprue healing thing that's going to go on, these guys are going to write a paper showing how MRE is the great way to follow, and I would completely agree, because it's, if you're going to scan people every 6 or 12 weeks, I don't really want to do even low-dose CT on those people. I can't get low enough in dose. I just wonder, do you have any pushback, as we do sometimes with the insurance payers? It took us a long time to kind of develop a pipeline through the clinic to get reimbursed for MRE, and it might be useful for some of the people in the audience who might want to go down this path, if you could comment if that was a challenge and how you dealt with some of the challenges in helping the clinic get some of these MREs, paid by the insurers.
It's interesting because we also have another study where we actually polled the physicians across United States to see what their choice of imaging study was for doing following patients with Crohn's, and what we found was most of them still preferred CT over MR angiography. There was an increasing acceptance of MR angiography, but one of the impediments for using MR angiography in routine practice was, one, insurance coverage. That was one of the factors. Second was that they were not familiar with the images, so they couldn't look at the images themselves. So and the cost and accessibility, those were the issues. Insurance coverage, I would defer to Mike G to see his thought, because he deals with MR angiography more.
Yeah, I mean, we get a lot of pre-auth issues from a lot of our young patients, and the single most important thing, I think, has been the ACR appropriateness criteria. Like that's the one piece of data that I've been able to use that's been the most effective thing on an individual basis. And the other issue that I'll mention is that there's a slow shift from waiting until patients are symptomatic to image to imaging asymptomatic patients, you know, because of all these expensive drugs and looking for cancer risk and which patients can they tailor the drugs on and stuff. And that's been the biggest issue for us, and I would say that's the area where we as a group need to do a better job of validating whether there is a role in the same way that we do surveillance imaging for cancer patients. Is IBD the kind of thing that it's worth it to get this imaging, and does it save lives, does it improve care? And so far the jury's out.
The comfort level among the referring clinicians is a very big issue, I think. I just finished a couple of weeks ago writing a book with gastroenterologists called Imaging and Gastroenterology. Don't worry, they're not about to replace us anytime soon. Based on this experience, we have a lot of job security. And I was actually pretty amazed at working with two high-level university gastroenterologists in writing this book, how little comfort level they had with some imaging studies that we would say, well, these have been around for quite a long time. And the comfort level in reading the MR stuff is really low in a variety of ways, not just for enterography, but I'm talking about liver tumors and a number of other things. And, you know, that you could say, well, that's not a very good argument for one imaging modality over another, but those of us who lived through the era when CT had to start competing with ultrasound and how quickly we saw the referrals going more towards CT, even when ultrasound had answered a question pretty well. It used to drive my ultrasound colleagues like Fei Lang crazy because we would do these weekly conferences and she'd say, why are you getting a CT on this? I told you all of that stuff by ultrasound. They go, yeah, but we know what we're looking at here. That's not an inconsiderable consideration when it comes to what drives the modalities. The other good thing, Joel, about being old is if they truly replace us completely, we can just retire. So I'm really not feeling.
My accountant says I can't retire.
Oh,
So.
okay.
I have one more. This is one of my colleagues asked me is what is the impact of gadolinium deposition in the brain and bones of pediatric and adult patients if they start getting MR enterography, because we always think of radiation dose, but now with all the data coming on, gadolinium deposition in the brain, if you start following up pediatric patients with multiple MR enterographies, what would be the impact? I don't know the answer to that. And
I already gave you the answer. Where are the ultrasound people? Why are they not getting angry? No, I'm sorry.
I think we have maybe only a minute or two left. Questions or other comments for the panelists? Yeah.
We made everything as clear as mud.
Did you hear enough of that to answer? If so, reiterate that if you would.
For patients presenting to the ER, it's predominantly CT enterography. The reason is our emergency physicians are not too familiar with sort of interpreting MR enterographies. Even if it's performed in the ER, we end up reading them. So predominantly patients get CT enterography. And that's the reason why our numbers have remained the same, because majority of ER patients get CT.
I think for us, sometimes if the patient's already established with an IBD specialist, their first call is to that specialist, and they actually will get them an MR. And it may not happen quite as fast as a CTE, but it can happen in an hour or so. I think the relationship with the referring services for the radiologist is probably at the heart of this matter. You're probably going to do what they ask, but the more they're involved in the decision-making and actually giving you some feedback also, the more you're going to be able to tailor what you think is the best thing for that patient.
Yes. Can we get is that microphone? Yeah, now you're good.
So one point we want to make is all the data that people compared in the past was based on old scanner Joel touched on. If you look at the new data on CT angiography in 2016-17, the radiation doses, even contrast media dose is so much lower. So when you weigh the risk of CT and look at the cost and other issues, CT for majority of patients, I personally think is much more attractive, and MR we should use it selectively in very high-risk patients or where we need to look for fistulas, as Mike said. We should exploit those benefits of MR and not make it a routine exam.
Okay, I think we have to break for the next presentation with Eric Paulson, so thank you all.
Okay, this brings us to the second portion of this session. And our first speaker is Dr. Eric Paulson from the Duke University, and he will address the topic of small bowel obstruction, when to worry. Eric?
Thank you very much, Rudy. Good afternoon. There's a surgical adage that says, never let the sun rise or set on a small bowel obstruction, yet most patients are not managed with surgery in the middle of the night. While small bowel obstructions account for 20% or so of patients admitted with an acute abdomen, most of those patients aren't treated with surgery. Rather, they're treated with nasogastric tube decompression and generally resolve without surgery. The problem with small bowel obstruction is while most patients do well, there's a subset of patients who don't do well, who go on to have complications, including bowel ischemia and bowel necrosis. And unfortunately, clinical exam findings and laboratory tests aren't all that helpful in identifying those patients who are at risk for those problems. So we are called on to stratify patients into risk categories and to identify those patients who are at risk of developing complications. So when do I worry? I actually worry about a lot of things, but I definitely worry when hurricanes are coming into the southeast. And when I see patients with small bowel obstruction, I worry when I think there is strangulation or ischemia, and that's more likely to happen when the small bowel obstruction is acute, when it's high grade, when there is a mechanical cause of the obstruction like a hernia, internal or external, if there is a twist or a volvulus, which of course places patients at risk for bowel ischemia. Volvulus and ischemia are more likely to happen in closed loop obstructions, so we focus on those. And I just look for any signs of ischemia. So for example, like in a case like this, the small bowel obstruction was from an incarcerated ventral hernia. You can see this decompressed loop of bowel coming out of that ventral hernia sac, or this case where there was a loop of bowel incarcerated in the inguinal canal, or this case where there's a loop of bowel incarcerated in the obturator canal lateral to the medial to the pectineus muscle, lateral to the obturator externus, I think. Is that right? Good. Thank you. Uncommon hernia, a lot more common in older women, probably due to pelvic laxity, nicely shown on this beautiful image borrowed from Dr. Federley's excellent textbook. Here's an example of a transmesenteric internal hernia after gastric bypass. And after gastric bypass, there's lots of different surgical approaches for gastric bypass, but almost all of them alter the ligaments within the peritoneal space and cause rents in the mesentery. And with those altered ligaments and with those rents in the mesentery, loops of bowel can create internal hernias and can give rise to volvulus and ischemia. Now, let me take a moment and talk about closed loop obstructions, because I think they're confusing and our surgeons are very interested in these because of the complications. So for a second, consider like a stocking or maybe one of those long socks that marathon runners wear. And if you were to pinch that stocking at both ends, you would have this loop. That loop continues to fill up with bowel contents and becomes distended. It continues to peristalse, and because it continues to peristalse, that distended closed loop may twist, causing a volvulus, and the loops of bowel heading up to that closed loop obstruction are also obstructed. So you've got an obstruction up to the closed loop obstruction, and then you've got loops of bowel that are really isolated from the remainder of the GI tract, where the closed loop obstruction is, that are particularly at risk for volvulus, particularly at risk for ischemia and infarction and perforation, and surgeons will take those patients to the OR in an emergency fashion. Closed loops often create a U-shaped configuration of a loop of bowel or a C-shaped configuration. You may see the beak sign that we remember from barium, where the loop of bowel goes up to a twist and creates a beak. You may see the whirl sign, where the mesenteric blood vessels are twisted when there's a volvulus present. The bowel upstream to the closed loop is generally less dilated than in the closed loop itself. Dr. Balthazar taught us about these in his famous, widely quoted article back in the AJR in 1994. Here's an example of a closed loop obstruction, this C-shaped loop of bowel that might have looked like this at surgery, and a small bowel obstruction up to that twist. And of course, when the bowel twists and becomes dusky, the blood vessels supplying that loop of bowel also twists, adding to the ischemia that's probably present just due to the high pressure of the bowel contents within the lumen. Here's an example of an obstruction here's an example of a closed loop obstruction, and you can see the actual C-shaped loop of bowel, the closed loop here that has ischemia, and you can see the swirling pattern in the mesenteric blood vessels indicating a twist. Closed loop obstruction. At surgery, that loop might have looked like that. Signs of ischemia are very important to look for. Patients with bowel ischemia have bowel wall thickening. Sometimes the bowel wall thickening is high attenuation due to the presence of blood. More about that in a second. You can have bowel wall thinning, paradoxically. More about that in a second. You almost always have some free fluid, almost always have abnormal bowel wall enhancement, which may be a target type appearance of the bowel wall, maybe decreased enhancement or asymmetric enhancement. You see edema or stranding in the adjacent mesenteria. You may see this whirling sign of the mesenteric blood vessels when infarction is present. Pneumatosis or portal venous gas are more likely to be present. If you get into this and try to write about it, you realize the literature is a real mess. All the studies are retrospective. The patient groups are very selected. There's not much path proof because ischemia can resolve. It's not always proven to be present. There's looseness in terms of the description of ischemia versus infarction in the literature. And the surgeon whose perspective is from the serosa may see a viable serosa, but the mucosa, in fact, may be ischemic. So surgeons are not that good at necessarily identifying patients with subtle degrees of bowel ischemia. We're not that good at the diagnosis. I worry about it as a result. You see wall thickening almost always, as in this case. You see fluid in the mesentery, as in this case. Now, the bowel wall thickening may be high density, as was reported in this article that was published in Radiology a couple of years ago, and that high density is due to the presence of blood within the bowel wall and indicates ischemia. It's fairly specific for ischemic bowel, but it's not very sensitive, and we hardly ever see that sign in our practice. Dual energy CT and virtual non-contrast scans may be helpful to look for that blood in the bowel wall. Paradoxically, bowel wall thinning can occur because dead bowel that's infarcted loses its tone, loses its nervous supply, and as a result can be distended and very thinned. And so that's sort of a secondary finding to look out for. You see edema around areas of ischemic bowel. As you see in this particular case, mesenteric edema is almost always present when there's ischemic bowel. Here the closed loop is kind of encapsulated, if you will, from the rest of the peritoneal space, and the edema and the mesenteric fluid is almost indistinguishable between the diseased and ischemic loops of bowel in this particular case. You will see abnormal enhancement of the bowel wall. Here's an example of sort of a target sign where there's hyperemia of the mucosa, hyperemia of the serosa, and edema of the muscularis propria level, not specific necessarily for ischemia. Other inflammatory disease can do that too, but it can be seen with ischemia. And here's another example of where you see this target appearance in a patient with a closed loop obstruction, enhanced mucosa, enhanced serosa in the setting of ischemic bowel from a closed loop of obstruction. Decreased enhancement or lack of enhancement, I think, is subtle, but you have to look for it. I think bowel wall enhancement in general is tricky. The small bowel enhances in strange ways. Collapsed loops of bowel enhance differently than loops that are a little bit distended. And so I think it's difficult to sometimes be definitive on decreased enhancement in the bowel, but when you see clear normal enhancement here in the jejunum in this case, and absent enhancement in the ileum in this patient who had a recent open AAA repair, that's a strong indicator of bowel ischemia, and that bowel might have looked like this, or in this case, perhaps a little more subtle. The loops in the upper abdomen, the jejunal loops in the upper abdomen look different with different and more vivid enhancement than the loops in the more distal jejunum, and this patient proved to have ischemic bowel. Dual energy CT, I think, can help us here. Our colleagues from the University of Wisconsin, Megan Lubner in particular, sent me this case, have looked at this, and this patient clearly has bowel ischemia using conventional technique, and there's pneumatosis in this case. Pretty straightforward in portal venous gas. But if you look at the low KEV image, perhaps the enhancement of the viable small bowel is more apparent than the non-enhancement of this loop of bowel over here in the left flank. But if you look at the iodine-only images, clearly there's enhancement here in the more anteriorly located small bowel and an absence of enhancement on the iodine material density iodine-only images. So I think dual energy CT can help us detect subtle areas of decreased enhancement moving forward. Here's one from last summer where the colon was ischemic. Using routine technique, there's decreased enhancement of the right colon compared to the left colon. Looking at the iodine overlay images, there's no iodine signal in the right colon. There's iodine signal in the left colon. This person had an ischemic right colon. Look for swirling in the mesenteric blood vessels, which suggest a twist of the mesentery, which of course are going to imply a twist of the bowel, putting the patient at risk for causing volvulus and putting the patient at risk for infarction. Here's a patient with a little bit of pneumatosis postoperatively with abdominal pain. And obviously that raises the question of bowel ischemia. But it's really important that when you think about bowel ischemia, look at the takeoff of the SMA, look at the takeoff of the celiac axis, look at the SMV and its branches and portal vein. Every time I put the word bowel ischemia in my reports, I go back and look at the vasculature supply in the bowel. I find abdominal imagers often don't look there very carefully, and unless you go look, you'll miss clots like this one might have been missed in the superior mesenteric artery. And we see that in our practice. You've probably seen it in yours as well, and it's important to include studying those arteries and those veins when you have suspected bowel ischemia. And this person had a jejunal ischemia from an SMA thrombosis. Pneumatosis suggests bowel infarction. One of my pet peeves of pneumatosis is it seems like when we identify pneumatosis on an abdominal radiograph, everyone wants to get a CT scan. I don't really think that's necessary, but that seems to happen. If it's clear pneumatosis on a radiograph, I think you're good. If you're not sure about pneumatosis, a finding that's really helpful is when you see gas in the mesenteric veins that drain the diseased loop of bowel, of course there's pneumatosis present. And so you don't really have to worry about whether pneumatosis is actually in the bowel wall. You've seen gas escaping the bowel wall into the venous drainage of the GI tract, and that's the same thing. And here's the world's worst pneumatosis with lots of portal venous gas and lots of pneumatosis. So in conclusion, when I see these patients with small bowel obstruction, my guard is up to look for complications. I, of course, look at the point of obstruction for a specific etiology and then look for things a surgeon might fix. I look really hard for pathology that puts the patient at risk for ischemic bowel like volvulus or internal hernias or closed loop obstructions. I look carefully for any evidence of ischemia. I think it's okay to overcall here. Undercalling these patients, I think, is a mistake. Our surgeons, I think, sometimes think we're really good at identifying bowel ischemia. I don't think we're that good, and so I think being very cautious is appropriate. I think it's important to get on the phone and talk to your surgeon about your concerns, and I do think dual energy CT can be helpful in sorting out these patients. So thank you very much.
It's a very comprehensive talk. I want to emphasize just the last thing which Eric said, and that is it's really important that you make a phone call. I was twice an expert witness for cases where this did not happen, and that was a detriment to the radiologist who did not contact his actual finding, and the delay was sometimes up to 24 hours, which in ischemia is a disaster. With this, I would like to introduce the next speaker, which is Dr. Isaac Francis from Michigan Ann Arbor, and he will talk about tumors and tumor-like condition of the mesentery and omentum.
Thank you, Rudy, and good afternoon. Unlike the bowel, what I'm going to talk about today is basically things that make the bowel float around. So I'd like to acknowledge a few people who have worked with me on this project and also who have written a paper that's in abdominal imaging. Much of the images come from this study, and the one person I think who's done a lot of work in this is Angela Levy from the previous AFIP. She's got a few landmark articles on this, so if you're interested, you can look those up. So I'm going to cover mainly the most common things, or even though these are uncommon, the most things that we have kind of seen in our practice, and hopefully they're the same for you as well. So first we'll deal with malignant mesothelioma. It's a very rare aggressive tumor, more common in men, and approximately only 15% arise from the peritoneum, mostly from the pleural cavity. They can arise from the pericardium as well. You can see the etiology is mainly to exposure, but there are other mineral fibers that also cause this. Radiation, chronic irritation are other causes. There are three main histological types. The epithelioid is the most common variety that you'd see. The sarcomatous variety has worse prognosis, and there's a biphasic one, and it's frequently associated with BRCA-associated protein mutation. There are two different types, not that we would actually see this very often, but there is a dry type where all you would see is tumor nodularity without ascites. When it's associated with ascites, it's said to be the wet type of mesothelioma. Now, mesothelioma, in addition to pseudomyxoma, can produce the so-called scalloped appearance. So the scalloping appearance is not typical only for pseudomyxoma. There are other entities that can produce this appearance. Similar to pleural calcification, the plaques are also seen somewhat less commonly in peritoneal mesothelioma. When it's very extensive, it can infiltrate the bowel mesentery and result in bowel wall thickening and may subsequently lead to bowel obstruction. Here's the so-called dry type of mesothelioma. I will just warn you, these entities all look basically alike, and we'll talk about the role for biopsy and a few studies which show what the findings usually are in practice. So this is the dry type of mesothelioma where you see the little nodularity, in contrast to this one, which is associated with ascites. You can see the free fluid as well as the areas of soft tissue thickening in the circled highlight. Now, as I said, the imaging appearances really overlap in many of these entities that we'll be talking about. So it cannot be easily distinguished from abdominal carcinomatosis, which is much, much more common, of course. But things that may be a clue is absence of a known primary tumor, absence of other metastatic disease to either organs or enlarged lymph nodes. Similarly, lymphomatosis can occur. It's a very rare form of lymphoma, but it's frequently associated with lymph node enlargement, but not always. And then you see the other two entities I've listed, tuberculous peritonitis, depending on what kind of practice you're in, where you may see TB peritonitis. We don't see that often. And an entity called primary papilloserous carcinoma, which I will also discuss. But the imaging appearances all look the same. There are potentially useful serum markers that that clinicians use for diagnosis. And one of them is, the most commonly used one is the serum mesothelin-related protein. So it's a serum marker. It's elevated in about 84% of mesotheliomas. And really all that tells you is you're dealing with a malignancy. It distinguishes a malignant lesion from a benign lesion. If you want to know more about if it's a mesothelioma, then you have to do immunohistological studies, meaning you need a piece of tissue from which you can estimate things like CEA levels as well as calretin. Those are the markers which are specific for mesothelioma. So in about 80% of patients, you can make a specific diagnosis of mesothelioma using serum markers as well as biopsy tissue and immunohistology. Here's the entity I said I would talk about. This is primary peritoneal serous papillary carcinoma. A few interesting things about this. It's also called serous papillary carcinoma, surface type. It occurs in older women, more common in white and non-Hispanics. There's a rising incidence in the Western world reported in the last few years, but this is due to tumor reclassification. These patients present with very nonspecific symptoms, abdominal distension, fullness, increasing girth, and GI symptoms. They have elevated CA-125, similar to what you would see in ovarian cancer. In fact, approximately 15% of the epithelial ovarian carcinomas that are called that are really primary papillary serous carcinomas. It manifests with ascites, peritoneal nodules, and peritoneal thickening, all that you would see similar findings in carcinomatosis as we discussed. You may see semomatous calcification in about a third of the cases. I'll show you an example of that. And they may have adnexal masses. So on imaging, we cannot tell whether these are surface mets on the ovaries or actually ovarian neoplasms. But you can see pathologically adnexal involvement confined to the surface of ovaries and the fallopian tubes is seen. So it's really not involvement of the ovary itself, but just the surface of the ovary. But unfortunately, we cannot make that distinction. And we already talked about the differential diagnosis for this. So here's an example, just showing you it looks just like a mesothelioma, basically. Soft tissue nodularity and thickening. This is a primary papillary serous carcinoma. And here's one showing semomatous calcification. You can see this calcification circled in yellow there, and here on the surface of the descending colon and adjacent small bowel, these are all calcifications. One of the pitfalls, of course, is giving positive oral contrast is that these may look like that and you would mask some of these, especially down in the pelvis when the small bowel loops get stuck down there. Most of the peritoneal tumors are stuck down in the pelvis and may look like calcifications may simulate bowel contrast material. So you have to manipulate the windows if you see one elsewhere in the peritoneal cavity clearly to see the extent of disease. There's an unusual entity called multicystic mesothelioma. So it has nothing to do with malignant mesothelioma. Its other name includes peritoneal inclusion cyst. It's a rare benign tumor with no relationship to the malignant variety. No history of asbestos exposure. It's seen mainly in premenopausal women with prior surgeries or infection that results in peritoneal scarring. So what happens in this scar tissue, hormonally active ovaries secrete fluid that become loculated in the pelvis. So they're really cystic masses. They're non-neoplastic reactive mesothelial proliferation results in these lesions. So they can look like mesothelial cysts or the cysts that we see in the peritoneal cavity sometimes. The imaging features, again, non-specific. You see multicystic masses. You may see the septations. This is particularly well seen on ultrasound. The ovary is really trapped within this, and you can see the differential includes all the cystic things we talk about, mesenteric cysts, lymphangiomas, etc. The treatment is surgical, but very often they keep recurring. Other treatments that have been tried include sclerotherapy, hormonal, and aspiration. I'll show you one from our practice. So basically, this is the ultrasound image. Here's the MR, and here's the CT, and you can see it's confined mainly to the pelvis around the area of the uterus and ovaries, and it's all fluid-filled with septations. Here's one from the literature, just showing another cystic mass in the pelvis, and here's what the PAT specimen looks like, just like a bunch of grapes or bigger fruits with cysts fluid within. Now, this is what we see most often, carcinomatosis. And they could be either carcinomatosis from a variety of primaries. Lymphomatosis very rarely can look like this. Then you have pseudomyxoma, and then we'll talk basically only about tuberculous peritonitis in passing very quickly here, because we don't have much time. So carcinomatosis is a common site for primary neoplasms, mainly from the GI tract and the ovary. It includes the findings that we've already talked about. It could be focal or diffuse with contrast enhancement, ascites seen. Here's a typical example with ovarian cyst adenocarcinoma. You can see the implants all over the place. Here's the primary tumor in the right side of the pelvis. Differential diagnosis, we've already gone through these, so I won't go through this again. We'll move on to pseudomyxoma. It's a result of a rupture of a mucinous tumor of the appendix or the ovary. There are two subtypes. One is the one that we are more often used to seeing and label it as well. So the type 1 has mucin and fibrosis. It's usually an adenoma or low-grade cancer from the appendix, or it could be from other parts of the GI tract. And type 2 is the mucinous carcinoma, which is more aggressive. It's usually a mucinous adenocarcinoma, GI tract, pancreas, gallbladder, and ovary. You can see the type really predicts the survival. So the one that we usually associated with pseudomyxoma is usually seen in men, and it's thought to be a tumor of the appendix. If you note, the tumor always recurs only locally. It does not have metastatic disease, doesn't go to lymph nodes or anything else. So that's the type that usually has the better prognosis. So the 5-year survival is like 75% versus the type 2, where it could be from many types of primary tumors, is a more aggressive tumor. This is what we usually see in pseudomyxoma, the so-called scalloped appearance to the liver, as well as you will see sometimes peripheral calcification in the mucinous deposits. The typical feature is this, may have calcifications. Unlike peritoneal metastasis, there are usually no soft tissue nodules. But if you put a density measurement, it's not going to measure fluid. And if you aspirate it, it's kind of gelatinous material which quickly solidifies in your aspirate tube. Now, peritoneal lymphoma is a very rare manifestation, can be seen in large B-cell lymphoma, can mimic carcinomatosis as we talked about, can be cause of ascites, hepatosplenic lesions, peritoneal thickening, usually associated with lymph node enlargement, but not always. So here's an example. Just looks like carcinomatosis, except this is biopsy proven to represent lymphoma. Here's the PET scan showing you all the smaller deposits, but more elegantly depicted that you can see in retrospect on the CT as well. I will move on to the infectious causes, which can look like that, and then talk about some unusual diseases, which I didn't know even existed, this gliomatosis peritonei, only quite recently I found out about this disease. Here's a patient with tuberculous peritonitis. You can see the changes in the lung parenchyma, small nodules distributed across over here. We don't see this too often, but if you're practicing in a large urban center, you may see more cases. Now, here's this entity which I never knew about till about maybe a dozen years ago. It's associated with immature ovarian teratomas, can be rarely seen in patients who have VP shunts. The pathogenesis is really unclear. And the prognosis and therapy is depending on what you get from the biopsy. If it's malignant cells, then you get chemotherapy. If it's mature glial cells, they consider it's benign and just follow it on imaging. On CT, it looks just like carcinomatosis. This one even has a scalloped appearance like pseudomyxoma, soft tissue nodules, thickening, and other abnormalities. Sclerosing mesenteritis, this is something we all have seen and see every day in practice. It's got multiple names: panniculitis, lipodystrophy, retractile mesenteritis. It's a non-specific inflammation, fat necrosis, and fibrosis, usually involving small bowel mesentery. Depending on the stage, you can see multiple appearances, and I'll show you the different features over here that's illustrated here. Can have a fatty collar, could be mass-like, may have calcifications in the late stages. Here's one just showing early stage with fat proliferation, mass-like abnormality with small lymph nodes, can become soft tissue, can get small bowel obstruction, and then you may get late stage with calcification. So you may see it in any one of these stages. Desmoids, no gender or age predilection. You can see that sometimes they could have other symptoms. 80% have familial adenomatous polyposis or MF history. They all had prior surgery most often. It can be also seen in rare autosomal dominant diseases. So basically you'll see soft tissue masses. You may be lucky enough to see an abdominal mass as well. These can have a variety of appearances depending on when you see them. And finally, since most of these are going to get tissue biopsy, we'll talk about at least what one study has shown. The study had 111 biopsies over a long period of time. In 79 patients, all had past history of cancer. 32 patients had no past history of cancer. And if you look at all the numbers here, 52 of the 79 had metastatic disease proven from their primary neoplasm, so colorectal and ovarian. In 10% of the 79 patients also, with prior history of malignancies, a new malignancy was found. So most often, we're just diagnosing cancer of one type. Either it's metastatic from a known one, or we're finding a new lesion. And even in patients who had no prior history of malignancy, new malignancy was found. So benign conditions as a cause for peritoneal or mental nodules seem to be very, very unusual. And that's been our experience as well. Thank you very much for your attention.
This very comprehensive summary of lesions, which often, because of their imaging overlap, cause diagnostic dilemmas. The next speaker is Dr. Elizabeth McFarlane from SSM St. Joseph Health Center, and she will talk on CT colonography, structured reporting and QA, and I hope you will address Medicare too.
Thank you very much to Gary and Dushyant for the privilege to be here. It's always a pleasure to be at SCBT within the collegiality and the innovation here. So CT colonography I'm going to discuss today, and beyond the early validation of colonography, we're going to talk today about the next level, the broader implementation in terms of screening in certain cohorts. And the emphasis there is quality. That is, with structured reporting, quality assurance, that allow this to be done with the highest of efficiency and accuracy. So that is the spirit of what we're talking about today. Now, to advance. Oh, it's left, sorry. Sorry about that. So a few comments about perspective and the demand, the need for colonography. After the early screening trials in 2003 with Perry Pickard at the Department of Defense, and then later with Akron and Dan Johnson in 2008, there was a landmark reimbursement accomplished, and that is with Medicare, for diagnostic CT colonography after incomplete colonoscopy. And this was achieved through local coverage decisions in almost all states, 47 out of 50 states in 2007. And we're going to talk now to follow in terms of where we are with screening. But first, in terms of one of the first feats in terms of lesion detection was the 1 centimeter and greater polyp, which now with good technique and high quality, we can do with 90%. This then led to the other types of morphologies, the 3 or 4 other types, but this being one of the more challenging one that really demands high quality, and that is the flatter lesion, or more technically, quote, the superficially elevated polyp. And we see this as an undulating nodular thickness along the fold here in 2D that we see in the 3D CT colonography view and compared to colonoscopy. And as we'll talk about with tagging, sometimes this can coat the surface of these lesions, as Picard will say, is like a beacon to finding them, as well as the use of CAD to help us detect these. But with good techniques and the understanding and recognition of this type of morphology, this is very much within our reach. Why is colonography important? Colon cancer remains the second leading cause of cancer-related deaths. An annual incidence of 140,000, 50,000 will die each year from colorectal cancer. And early detection is feasible, and it obviously is the key to prevent the morbidity and mortality. Secondly, there are not enough gastroenterologists to do colorectal screening with structural imaging with optical colonoscopy to meet this need. And thus, from that gap, we have the opportunity to have a new field of expansion for radiologists in terms of colorectal screening. And just to step back a minute in terms of cancer detection, we look at the other modalities within our field. Mammography for decades has looked at obviously the detection of early breast lesions and breast cancer detection. More recently, CT lung cancer screening in terms of pulmonary nodules. We will soon have the talk in terms of MR of rectum, maybe more for staging than longitudinal detection. And we have MR prostate. So among these growing number of modalities, we really are in an era where radiologists can join multidisciplinary teams in terms of the longitudinal detection and surveillance of common cancers, breast, colorectal, lung, prostate. So it is an exciting area of expansion for us, and yet with colonography, our efforts still remain limited. And some of those might be due to, I think, frankly, some misperceptions about reimbursement. The RVUs for colonography are very similar to CTA aortoiliac or CT PET, 2.3 to 2.5. But probably the hardest one is that within the busier and busier schedules that we face with higher volumetric data, we just feel that it's too long or too tedious to do. And that's where we need to kind of break down. I think, again, that's the spirit of SCBT, that with new technologies that have been advanced, how do we implement those efficiently? And again, that's where quality comes in to improve that. So just in terms of from a screening success, almost a decade later, now in 2016, U.S. Preventative Task Force came out and incorporated both stool DNA and CT colonography into screening algorithms. And if you remember, this was achieved in 2008 by American Cancer Society, did give CT colonography endorsement for screening, and that led to private payers who are still there reimbursing CT colonography for screening. But back in 2008, U.S. Preventative Task Force had a non-decision that led to CMS giving a non-coverage decision. So this 2016 U.S. Preventative Task Force is very exciting, giving colorectal screening at large an A rating, and the two new players on the block, stool DNA as well as CT colonography, as part of the colorectal screening guidelines. Now, Medicare is still balking at a national coverage decision over screening. As others will say, the majority of screening is in the 50 to 65-year-olds, the first decade and a half of what we go through, the first 15 years. But we will continue to fight, and I think we will overcome in the chaos right now of healthcare reform. When CMS can get back on this page, I think we will be able to push this through shortly. I'm confident of that. So in terms of today, why does quality matter? What are some of the things at ACR in terms of the near-dear quality metrics that do exist? What are some of the key elements to ensure high quality efficiently? And at the end, we're going to go over some case reviews of looking at some of these difficult cases, but yet how to have a broader perspective to get through them, and some interesting tough lesions that with high quality we can see. So, high quality, in a nutshell, drives efficiency and drives accuracy. And if we as radiologists want to do these larger volumetric acquisition type techniques. If we can front end this with quality, we can make our jobs incredibly easy, and these exams can be done in 10 minutes or less with high quality when they're negative studies. High volume practices have been achieved. In fact, I had the privilege to go through, Obama in 2012 had a CT colonography. He didn't want to go, give over the powers of state. And I visited the Bethesda where he was done. And literally, as patients were going into the room, they were bumping the shoulders of patients coming out. And one CT tech was manning, getting the patient on the table, insufflating the patient, coming out and scanning the patient. Again, that's a very high volume environment, 10 a day. Wisconsin was very similar to that. So it can be made into a turnkey operation when you put the right infrastructure behind it. Obviously, it's a little more challenging as we start off with lower volume practices today, but it is something to lessons to be learned from those who have done it successfully. And in the future, reimbursements like we see across radiology will likely be linked to metrics of quality. So when it comes to colonography, the bowel prep that the patient does before CT and then the bowel insufflation that the patient goes through at CT are everything. And if we can achieve that consistently, we can get these patients not only through in a comfortable way, but also we can read them efficiently and accurately. Remember with the bowel prep, which involves tagging, tagging will impart high density to residual fluid that's left behind so that we can see submerged polyps underneath. And it also helps coat the surface of polyps, that especially in those flatter or superficially elevated lesions, that can be a landmark in terms of detecting this rim of contrast that can go across those types of lesions. So tagging with the bowel prep is very important, and it simply can be 50 cc's of Omnipaque the night before the exam. That's really what is done traditionally. And on the same day incomplete colonoscopy, if you want to do it on the same day, it's typically 30 to 50 cc's and waiting a couple hours afterwards. So if they can get that in the colonoscopy suite before they travel, that's ideal. Insufflation, this is just an example of what the small tricks that we can do at insufflation. This was a 50-year-old male who struggled in terms of getting this right colon open with supine imaging, and by putting him left side down, nicely was able to distend the right colon and cecum. So positioning can be used to exploit what segments are not done to keep it to 2 views, and more patients are doing in decubitus views because it's just easier for them to do that rather than supine and prone. Now, in terms of the registry that began, we developed it in 2008 and it was launched in 2009. There are 3 process measures: the rate of adequacy of the bowel cleansing and insufflation, the adequacy for screening CT, in other words, using low-dose techniques and thin slices, and the adequacy of diagnostic CT colonography. I'm just kind of doing this in broad strokes. And 3 outcome measures. That is, following up on those polyps that are 1 centimeter and greater, that they go on to optical colonoscopy. And ideally, this is done in a coordinated way that those patients that are positive at CT have an option to go to same-day colonoscopy. And in the same way, those patients that fail at colonoscopy can come for same-day colonography to complete those. That saves the patient's bowel prep, which is so important. The second outcome measure is the rate of perforation, very, very low, and then the extracolonic findings, which have been a lot in the realm of Medicare's concern, and yet when you look at what are clinically significant that lead to additional imaging in screening cohorts, it's 5 to 10% in terms of that. Key elements to ensure high image quality. Patient selection is everything, doing the right test for the right patient, and we'll talk about this in a minute. The bowel preparation and the bowel insufflation. And I think what goes with these common environments within mammography and lung cancer screening and so forth are nurse navigators and study coordinators that you can start to have synergy among your infrastructure. And it takes the burden off the radiologists and creates some common infrastructures to allow the processing of these patients ahead of time. And from the practice parameters that ACR recently revised in 2014, patient selection, we talk about contraindications, inflammatory states, symptomatic colon-containing hernias. The same-day polypectomies can be, some radiologists will say based on communication, they will do no patient that's had any polypectomy just because of the risk of, what really was the communication of how deep that was. And others have better lines of communication that if it really is a superficial cauterization, that they will do the same-day a CT colonography to complete it. And in terms of front-ending this process, very simply, order forms go a long way. And this is just an example of the order form that can go over what type of test is it, what's the GI history or family history, is IV contrast to be used, and what was the bowel prep, for example. And in terms of the bowel prep for the patients, where they outline what is done, why they go through stool tagging, how they go through that and controlling their clear liquid diet the day before, and drinking the Tagatol or the Omnipake for stool tagging, as well as going through the catharsis. So these things have been very important to distribute to the patients for clarity. Now, very important with everything is structure reporting and obtaining key images. Referring physicians and colonoscopists really don't want to go through 800 images, but they want to see the clinically significant lesions shown to them in 2D and 3D, and then the nice CT edge-enhanced or barium minimal look that shows where these lesions are. So with the structure reporting goes the selective imagery that really helps tell the story, and just a quick overview. CRADS, modeled after BIRADS in breast, has been around since 2005. Mike Zales and developed this, and it is from C0 of being an incomplete study to a C4 being an advanced mural lesion. We've decided from American Cancer Society that the polyp threshold is 6 millimeters and greater, that a patient potentially would go on to colonoscopy. Now, some will defer that. They'll say that someone, maybe an older patient with other comorbidities, they may choose to follow an 8 millimeter polyp. But the polyp threshold is 6 millimeters and greater. And similarly, the extracolonic findings can also have a grading scale. And as I said, when we really look at studies that have used this type of structure reporting, we've shown that 8 to 11% will have the potentially important extracolonic findings. What's interesting about modeling, when you talk to those who do cost modeling, is even though finding early undetected lung cancer or renal cancers most commonly, that really hurts the modeling in that it costs more to find earlier cancers and be preventative in those years of treatment after that than to allow that patient to present later with more advanced disease and live less years. So it's interesting when you get into the philosophy of cost modeling with these extracolonic findings. But we as radiologists, having said that, have to be efficient. Can't overcall small things that only lead to additional studies. And we have to really watch, the small hypodense lesions in the kidneys and in the liver, for example, and not overcalling that. And finally, let's end with a case review of some of these examples of poor to excellent image quality in different types of lesions. So this is just an example of a gal that came in a couple weeks ago, and we see that this is a decubitus view and then the supine view. And this was just an example that although she had retained fluid, it's very well tagged, and there's paper-thin wall. It's fairly open. The haustrations might be a little bit thick there, but not bad. It's not phenomenal, but it's fairly good. And so with that kind of tagging, we can be able to see through that. And one thing of efficiency is that rather than looking at this kind of window level, we broaden the window so that we can actually see through the contrast and look for the submerged lesions as well as those that have air interface. And wrapping up here in just a minute, this is another example of an elderly patient, same-day incomplete colonoscopy. And although she had a lot of fluid, one, it was well tagged, and again, her distension was paper-thin walls, and we can see that although this can look like a polyp, she had dropping areas of probably pill particulates through this. And so, although you might say that that's a lot of fluid to have in the colon, we can exclude the advanced mural cancer. So although polyps, smaller polyps, might be less tedious with this much floating stool or pills, whatever she has, we still don't miss the opportunity to exclude advanced mural cancers. And finally, here's some flat lesions in the right colon that with good image quality, these are the more challenging lesions, and this was that nodular thickening next to the ileocecal valve plane here. These flat lesions that we can see, and this is just another example in the rectum, finally, that again, it's this soft tissue nodularity that we see here, and it's this broad area on the 3D, and even on the supine view that has tagged material underneath it, you see the difference between the mesenteric fat and that soft tissue nodularity contrasted with the high contrast. So these types of lesions can be made. They're most common in the rectum in terms of the lateral spreading tumor and the flat lesions in the right colon. So those are areas to really keep an eye out for. So finally, achieving high-quality exams is possible with well-organized service lines that ensure efficient and accurate review. Bowel prep and insufflation are key. The ACR provides a quality database that you can be a part of. And when faced with poor exam quality, focus on not missing the opportunity to exclude the advanced mural lesion, which sometimes can be the most important thing they're trying to do, especially in elderly patients. Thank you so much.
For this excellent talk. It looks like there is hope for Medicare here that they will come through. And the final presentation is, and I hope I don't screw up that name, Dr. Ihab Kamel from Johns Hopkins. And, oh, here you're coming, okay. And he will talk on MRI of rectal cancer.
Good afternoon, and thank you very much for the introduction. Certainly a pleasure to be here, and I want to thank the committee for the invitation. MRI of the rectal cancer, certainly something that we see in our practice and significantly increased over the last maybe 5 to 7 years. And I just want to put a couple of anatomy slides, not to go over the anatomy, but to remind myself that I want to make sure that I describe certain anatomic relationships that are going to be very important for staging, for surgical management of these patients, and therefore will determine survival and outcome. Very important to determine the location of the mass and its relationship to the levator ani muscle, to if it's a lower rectal mass, relationship to the internal and certainly the external anal sphincter. And you may want to look through the axial, coronal, and sagittal planes to make sure that you see these relationships here. You see the puborectalic muscle, you see the ischorectal fossa and the fat within it. Certainly very, very important anatomic landmarks that we need to pay very careful attention to, particularly the mesorectal fat and fascia. Here in the coronal plane on T2, you see the mesorectal fat and the mesorectal fascia. These are very important landmarks, and you see them here in the axial plane because tumor involvement here will upgrade that stage. And certainly if the fascia is involved, that's another poor outcome for the patient. For surgical planning, we need to be very careful with defining the involvement of these structures. The fat contains the rectum as well as lymph nodes and vessels, and that is all enclosed within this fascia. Therefore, it's very important as part of surgical management, which is total mesorectal excision, if you include the entire tumor with a safety margin that significantly reduces the risk of recurrence. So this is part of the very important indication why MRI in rectal cancer. You heard Beth talk about technique, and this is also very important here. If you're starting to do rectal MRI, or if you've been doing it and you're not very happy with the results, you need to emphasize to the technologist technique. 3T here is definitely advantageous. I would definitely use 3T over 1,5T. You want to replace the rectal content, whether it's fecal matter or air, with gel, because otherwise you're going to get a lot of artifacts that could impact your staging. We like to give glucagon if there are no contraindications because we want to freeze bowel motion. proper imaging plane is very important. And I like to emphasize to the technologists that my axial and coronal planes are related to the anatomy of the rectum, not anatomic axial and coronal to the pelvis. This is very important because it can help you identify involvement of the mesorectal fat and fascia as well. So technique here is very important. Here's one of the important pitfalls or a pearl when you're scanning these patients. I like to have at least one plane with a wide field of view, preferably the sagittal plane, because this is one example where this is the last axial slice in this plane. And you can see here it's missing a significant component of a high rectal cancer. I like to see that sagittal plane because I make sure that I see the entire extent of tumor, and oftentimes the lymph nodes are best seen in this plane. I like to look at the presacral space, and oftentimes I see the lymph nodes very nicely here. So be very careful when you're setting these protocols. Sometimes the techs want to get a small field of view to be able to improve that resolution, but oftentimes you may be missing some anatomic landmarks or lymph nodes, particularly high presacral areas. So in our practice, we don't get ultrasound anymore. The indication for rectal cancer is definitely in staging rectal cancer. We use the TNM classification when report other critical findings. We use it to assess response to therapy and also to assess post-radiation or post-surgery complications. We also assess recurrence in these tumors, and the recurrence rate is up to 5 to 10% depending on the literature. One of the more important findings that you need to report, and certainly an important indication to getting an MRI, is distinguish T2 from T3. T2 involves the muscularis propria but doesn't cross it. If there's involvement of the mesorectal fat, it becomes a T3. So this is very important, and it's important to highlight that in the report as you look at these cases. This is an example of a T1, which I didn't see any tumor, and I don't expect anybody to. The surgeon told me that it is anterior. The MRI is still very useful because it confirms that there is no involvement of the mesorectal fat, mesorectal fascia, and there are no lymph nodes. But we don't expect to see a T1 stage. However, a T2, you expect to see it, and it's very important, as you can identify here, to make sure that there is no involvement of the mesorectal fat. Like the coronal, axial, and the sagittal, we look very carefully, make sure that this is a localized disease that is not beyond the muscularis propria. A T3 is clearly very concerning here when you see this nodular involvement of the mesorectal fat, and this is on the T1 post-contrast. You see it on the T2 as well, this nodule extending beyond the contour of the tumor into the mesorectal fat. When other organs, surrounding organs, are involved, such as in this case, there's extension of the tumor into the posterior aspect of the uterus. This becomes a T4, definitely significantly worse outcome. This is a T4 extending into the presacral space. Again, on the sagittal view here, you nicely see these lymph nodes, oftentimes a little bit more difficult or challenging in the axial or coronal plane, nicely demonstrated in the sagittal plane. Lymph nodes are important because they affect the staging. If there are 3 or less, it's an N1. If there are more than 3, then it becomes an N2. And sometimes they're challenging in the axial plane, especially if you're using 1,5T as I'm showing you here. But it is important to look very carefully, and the size of the lymph nodes are also very important. If they are 5 millimeter or above, they become very concerning. Here's another example of lymphadenopathy. There are quite a few here. These are 4 more lymph nodes. then it becomes an N2. What makes lymph nodes suspicious? If they are 5 or more millimeters, if they have mixed signal intensity on T2, if they're spiculated, if they have an indistinct border, if they are very rounded rather than flat or with a fatty hilum. And here's again example on a sagittal plane. You see quite a few lymph nodes. Again, we don't do a good job with lymph nodes in general. I think we can improve our techniques and we can improve our specificity, and there are certainly contrast agents and other techniques such as diffusion that can enhance our detection as well as characterization of these lymph nodes. But in general, this is still something that we can improve our specificity. I've also seen lymph nodes that enlarge post-radiation, and it's important to realize that because we don't want to overcall it. Sometimes this is reactive, and they can enlarge a little bit, but certainly not suspicious, especially if the tumor is responding to treatment. There's no reason why the lymph nodes should increase as well. Part of our reporting, and you heard about structured reporting, and it's very, very important to report the circumferential resection margin, extramural vascular invasion, depth of mesorectal invasion, and distance from the levator muscle, because again, these affect the staging, they affect the risk of recurrence, and therefore survival. CRM is the distance between the edge of the tumor and the mesorectal fascia. This is very important because the shorter this distance, the more the risk of recurrence, and it could impact survival. Similarly, if there is extramural vascular invasion, if there are nodular enhancement of these vessels, becomes very, very concerning for extramural vascular invasion. Again, if that's the case, there is a risk of increased recurrence and poor survival. The depth of mesorectal invasion, the deeper the invasion, the worse the prognosis. Similarly, if the tumor is involving the levator muscle, this could be a problematic at surgery and may not be a surgical candidate in some cases. So it's very important to report these structures and make sure you communicate them with the referring clinician. One of the indications for MRI that we see in our practice is assessing response to therapy. And this is one such example where there is good response to therapy. You see this mass here, enhancing mass in the lower rectum with significant shrinkage post-therapy indicating favorable response. So MRI here can be extremely useful in assessing response to therapy. And certainly after surgery, you assess for any recurrence, for post-operative complication. This is one example where there was a small fluid collection post-operatively. It resolved over time, but certainly one of the more important findings that we look for post-surgery is assess the risk for recurrence. And this is one such example where there was a subtle finding on CT, subsequently confirmed on PET. On MRI, you can see the nodule on T2. You see the rim enhancement and the nodular configuration of this area with a little bit of asymmetry. On diffusion and ADC, there's restricted diffusion. So all of these findings confirmed the presence of recurrent disease. We've seen a whole set of other tumors in different settings. This is one example of adenocarcinoma that occurred in a patient with Crohn's disease. On the axial T2, you see this bright T2 signal within the lower rectum with the restricted diffusion, with rim enhancement and central necrosis. On the sagittal T2 weighted image, you see this large mass involving the anal sphincter as well. This is a patient with Crohn's disease that had adenocarcinoma of the rectum. This is an example of a rectal GIST, certainly not a common tumor. It is fairly rare, actually, in the anal canal. And this is a recent case where you can see a large mass, cystic and solid component. This is a fibroid. This patient has a fibroid flipped here anteriorly, but this large mass has cystic and solid component. You can see it on CT. The patient subsequently had an MRI, and you can see here the fluid level, the enhancement, the restricted diffusion, very complex, large, cystic and solid mass that turned out to be rectal GIST. So in summary, MRI is becoming an essential imaging modality for imaging rectal cancer. It is certainly replaced ultrasound in staging these patients. We don't get ultrasound anymore, at least in our institution, and we've seen a significant surge in volume in these patients. Proper technique is essential, and it's very important to prep the patient well. It's very important to have the right imaging plane, and it's very important to have at least one field of view that is a large field of view to make sure that you look in the presacral area, especially for adenopathy, and make sure that you include the entire tumor, because oftentimes otherwise it will be missed in if a small field of view. The most important role of MRI is in staging. The TNM staging is very important. CRM is also very important. Lymph nodes can be challenging. Sometimes we don't see them as well. Often we overcall them post-radiation because they increase in size. However, that's something that we can improve on as far as technique, as far as new sequences such as diffusion and so forth. And with that, I thank you for your attention.
Excellent presentation. Could the speaker come to the podium for questions, please? Are there any questions from the audience?
Question for EHAB. Do you feel that the rectal gel installation affects the accurate measurement of the CRM?
I don't think so, but it's an interesting question. I don't know if your experience is otherwise, but I think that the distension is essential, because otherwise, if there's any air or any fecal matter, it definitely impacts our even visualization of the entire extent of the tumor. So, but I don't know if it could impact the CRM.
We've had some debate about whether distending the rectum too much with gel might artificially cause the CRM to be less than it should be.
I remember having similar debates when we were using endorectal coil for prostate imaging, and the compression on the prostate by the endorectal coil, whether it could impact our localization and segmentation. But it's actually a very interesting question, and if anything, it will probably underestimates the CRM or will make it worse, certainly, right. Anybody from the audience has a different experience, or?
I was going to ask you the similar question, because we debated it, and sometimes we give it depending on the location of the tumor, but I don't have a great feeling for it. But I was going to ask you about contrast. You give it to everyone, intravenous contrast?
Yes. I think that first run is just always, the enhancement is so vivid that we give it for everybody. It helps for the lymph nodes as well. Okay,
that's very helpful. We argue about it in our practice, so thank you.
The argument against it, I guess, is it needed?
Depending on who you read, it's not necessary. It takes time, it costs money, but I have to admit,
it's part of our standard protocol. Yeah.
Thank you.
Yeah, sorry, another question about rectal gel. One of the other reasons we don't give it routinely is for the mucinous tumors. We sometimes feel it makes it harder to distinguish because they're so T2 hyperintense. Have you guys experienced that at all, or?
It's certainly a possibility, but it hasn't been an issue in our practice. But it's a good point.
I have another question for you. Sorry. Some of the literature talks about differentiating between nodes and nodal deposits. So nodal deposits are supposed to be less than 3 millimeters. So my question is, like, can you differentiate between nodal deposits and non-enlarged lymph nodes, which are next to the circumferential resection margin?
I think that's a very good point, and that's why I emphasize the limitations that we have nodal disease and nodal deposits. Certainly, we just don't do a good job distinguishing between the two, and we often have false positives as well as false negatives. I think the future is going to be the pharmaceutical agents or the labeling that somebody with a molecular imaging expertise such as Marty Pomper at Hopkins, they have very specific targeting for nodal disease in the prostate, and I've seen very, very impressive results. But MR, we try to use diffusion, and we try to distinguish between nodal involvement and nodal deposit, but we haven't had much luck.
Sorry. Two questions for Beth. This is about CT colonography. In your practice, what has been the total number of cases you perform on a daily basis? And second is, do you ever consult with the patient about the CT colonography report, or ever patient asked to be consulted by a radiologist? Yeah.
You know, it varies. Probably it's handfuls in a week kind of thing, you know, that we would do, and it depends on the colonoscopy. Still, some of our highest volumes are same-day incomplete colonoscopies rather than screening, even though locally, you know, what's interesting about gastroenterology is they don't want to give up screening. And despite being there for them for those same-day incomplete colonoscopies, they still kind of hold on to that. I think if you realize the Multi-Society Task Force guidelines just came out, and they even put FIT above CT colonography more for various reasons. But I think as more and more gastroenterologists get comfortable with this concept, I think we will see greater referrals for screening, because that's really where the market is, to be able to do that. The second question, which you know you all do so well at Mass General in terms of going over cases, we haven't been asked yet, but if patients do want to know, we can. And I think what's really going to be helpful is patients that who are otherwise non-compliant, and they finally come in for colonography, and they really don't want to have a colonoscopy, but if you literally show them a picture of a polyp, I think they're going to have a much better threshold to go and have that colonoscopy. So I think it is going to play a role in the future as more and more screening comes out, especially in those patients who potentially could be non-compliant to follow up a colonoscopy. But those are great questions.
My question is for EHOB. Do you have any experience with iron-based contrast agents like ferumoxytol or others for helping to stage the lymph nodes for rectal cancer?
I don't, but certainly there's interest, and I'm not sure. Are you using it?
We've looked at it tentatively in some volunteers, and we're not finding much uptake at all, even with relatively high doses.
As I mentioned, I've seen very impressive results with molecular targeting particle that's specific for the prostate, and I think that would be a game changer, especially for nodal disease.
Yeah, perhaps maybe PET-MR, even FDG PET-MR.
Yeah.
I have a question for Isaac. What's the exact role in your practice for biopsy? Your last slide showed a paper which you quoted. It seems to me there's so much overlap in the imaging findings between these diseases. Could you explain to us how you handle it?
As I showed in that study, which is from a different institution, we kind of looked at what we do, and it mirrors similarly what was done there. Most often we are asked to biopsy for suspected peritoneal metastasis from a known primary. That's about the most common indication. If they can't get fluid analysis with cytology positivity, then they would ask us to biopsy a solid peritoneal nodule. And sometimes in a patient even with no history of malignancy and you have findings, we would biopsy them to find out what it is due to.
Okay. And finally, Eric, Duchamp has addressed dual energy and all that. How often do you use it, especially considering you talk about ischemia, closed bowel leaks, and so on?
In regard to dual energy CT, and we'll get to you next, dual energy CT for the acute abdomen, we've we've started we use dual energy with our ED scanners, and we're trying to collect data to look at this issue of bowel ischemia, and can we do a better job with it? So it's underway. There was another question, I think, as well.
Okay, go ahead.
I had a question for Dr. Camille. One thing is, how do you differentiate between this desmoplastic reaction around the tumor versus stage 3? And the other thing is, how do you assess tumor treatment response, whether it is reactive changes versus versus residual tumor? We have found diffusion-weighted images very useful in those treatment patients, but is there any hints?
That's been our experience. I think diffusion is key here. I think that if the tumor continues to restrict.
And how about the desmoplastic reaction versus extension of tumor into the mesorectal tract?
So if there is a restricted diffusion, then we suspect that this is all tumor involvement, not a reactive response. We've seen the reactive response, as I mentioned, in post-radiation changes where the tumor may swell a little bit or the lymph nodes may increase in size a little bit. But that's why I think the more long-term follow-up can help distinguish between the two. But certainly there's a lot of overlap that is still yet to be resolved. Correct.
One more thing. Listen, after an excellent afternoon of lectures, I know you all are interested in a beverage. And so immediately after this session is over, which will be 1 minute from now, in the exhibit hall, which is right next door, there's a reception until 6:30. Would encourage you and a guest to attend for some refreshments at that time. Thank you.
For over 20 years, Meetings by Mail has provided the gold standard in enduring materials CME. With courses specializing in body imaging, breast imaging, vascular ultrasound, nuclear medicine, and echocardiography, our activities can meet your entire self-assessment CME requirement for maintenance of certification. We collaborate with renowned institutions such as the SCBTMR, Duke Radiology, Penn Radiology, Cleveland Clinic, and many more in order to create high-quality content for the home viewer. Products are available in DVD-ROM format and new this year, streaming online. 400 fully accredited hours of CME are available for your review. Presentation topics are searchable by session, faculty presenter, and keyword search. All video has optimal image clarity with audio cued to every slide. Bookmarking ability allows you to leave the activity and resume seamlessly regardless of device. We have incorporated all CME applications so you can get your certificate immediately after completing an activity. So if you can't make the meeting, bring it to you. Meetings-by-mail.com. Try Meetings by Mail and make sure you're never too busy to learn.